Everybody ready? Hungover? Well, this lecture will just make you feel even worse, I'm sure. A few years ago, Dr. Miller asked me to give this talk, and it's a little bit of it's a very challenging talk because it's a very dry topic. That being said, the one thing to understand is that basic science and pathology cover 30% of your boards. This is incredibly important, but the other thing to realize is that the basic science on the board is very easy. Okay, you might find that hard to believe. I took my boards five years ago. I know what you guys are going through. I understand how this can be a very difficult topic to learn, but the basic science and the biomechanics portion of it are fairly straightforward. They don't try to trick you. They don't try to make it difficult. It's just you have to know, you have to be familiar with the concepts. And if you are, you'll do fine on this portion of the test. You know, Dr. Miller always says, the test is always easy if you know all the answers, right? So let's get started here. This is a 3-hour lecture, so I'll try to make it a little bit amusing as well, because it is a very dry topic. But as I mentioned, it's incredibly important. Everything's in your syllabus, so you can review it later on. We're going to move very fast. This is going to be like drinking from a fire hydrant. But the critical information is in your syllabus. Anything on the screen that's red, outlined or highlighted in red, has been past test questions or important concepts. Okay? I'd like to just acknowledge a few of my contributors. Dr. Brinker, who's done a great job writing this chapter and modifying it over the years, my partner, Dr. Miller, a few of my residents. I've reviewed all the OITEs from the last 5 years, self-assessment exams. There's a section of this talk, after each component of the talk, we're going to go over about 30 or 40 questions. So we're going to go through that as well. Those are the highest yield questions that occur, that are seen from year to year. So it's a very high yield portion of this talk. The concept here is to give you the information that's tested most routinely. So obviously it can't cover all of basic science or all of bone biology, but the most important concepts. Lose credibility right now. I'm a huge Redskins fan. Not only are you going to learn basic science, you're going to learn a little Redskins trivia today. And obviously, I've been at the University of Virginia a long time, 15 years now. So, as Dr. Miller mentioned, the basic science topics have been divided into 3 sections. I'm going to cover bone, neuromuscular and connective tissues, and basic biomechanics. Dr. DeHart's going to speak tomorrow, and then Dr. Schuler is going to speak on Saturday. So it's essentially 8 hours of basic science. And as it is a very difficult topic, but again, it's incredibly important because of the percentage of questions that come from this area. This job isn't ideal. Again, it is very dry. I'll try to make it as fun as possible. I'm, again, a Redskins fan. People are questioning Gibbs, whether he's going to do anything. I still have the faith, just like you guys should have faith in this guy. Believe it or not, he walks around the OR in a cool suit because he sweats so much during surgery, and he always has to be cooled constantly. So, imagination is more important than knowledge. That may be true in this case. Unfortunately, you have to know the answers to these questions. Can't make them up. So let's start. We'll start with bone right now. We're going to talk about histology of bone injury and repair, conditions of bone mineralization, bone density, and bone viability, which is the hardest part of this lecture. And we'll try to go through that slowly, but I'll emphasize the points there so that make it as easy as possible. My goal here is to, yes, make you understand the basic science and biomechanics, but more importantly, prepare you on how to answer a lot of these questions. A lot of this will be a review for you, okay? Types of bone, this should be familiar. Lamellar and woven. Lamellar is divided into normal cortical and normal cancellous bone. Woven bone is immature, seen in immature and pathologic states. Types of bone, woven again is on your left and lamellar is on your right. Lamellar is more organized. It is oriented according to stress. Woven bone is more hypercellular and is less well oriented. Lamellar bone organized, less cellularity, it's stress-oriented according to Wolff's law, which everyone should be familiar with. Cortical bone comprises 80% of the skeleton. It's a slow turnover rate. It's composed of osteons. It has a high Young's modulus. And we'll talk about that more in our basic science section. There's a high resistance to torsion and bending. Cortical bone, as you can see, is very hypocellular and well organized. And again, it's oriented to stress. The functional unit of a bone is an osteon. This should be a review. Again, they like some of these questions. Volkmann's canals are the vessels between the osteons. The interstitial lamellae is the connective tissue between the osteons. Cement lines is where you end up getting fractures through. And the canaliculi are the communications between the osteons. So remember, the functional unit of bone is an osteon, and that's been questioned before. You can see the organization of an osteon. And again, the cement lines, the canaliculi, as well as the central vessel or the Haversian canal. Second type of lamellar bone is cancellous. It's less dense than cortical bone. It has a high turnover rate. It's more elastic than cortical bone, and it has a smaller Young's modulus of elasticity. And you can see how it looks histologically or with scanning EM. Woven bone, seen in immature states, fracture callus or pathologic states such as infection, malignancy, and stress reactions. It's weak, it has random organization, it has increased turnover, it's not stress-oriented, and it's hypercellular. There's been questions in the past where they want you to compare woven bone and lamellar bone, and the answer was woven bone is more hypercellular. Let's talk about the types of bones seen, the types of cells seen in bone. Now, osteoblasts are the bone-forming cells. This is all basic biology. You haven't seen this in a long time, but this should be at you should have this information, or give me questions, because they ask very direct questions on the boards. They're bone-forming cells. They're derived from undifferentiated mesenchymal cells. They synthesize type 1 collagen, and it has a high alkaline phosphatase activity, which is a marker of bone formation. The receptors are a favorite topic as well. The osteoblast receptors. There's a receptor for PTH on the osteoblast. Now, osteoblasts, that seems a little counterintuitive, because osteoblasts are involved, PTH is involved with increasing levels of calcium, serum calcium, and we'll get into that section. But so you would figure that it acts on the osteoclast. It does not have a direct effect on the osteoclast. It has a direct effect on the osteoblast, which sends a secondary messenger to the osteoclast, and that's how it activates the osteoclast. This question comes up over and over and over again on OITEs, and was actually on my board exam a few years ago. There's 125 vitamin D, which is the active form of vitamin D. The osteoblasts have a receptor for this. You can see what it does. It stimulates matrix formation, glucocorticoids. The glucocorticoids, prostaglandins, and estrogen also have receptors. Osteoblasts also have receptors for these. They won't really ask you the specific function, but that's there for completeness sake. We'll talk a little bit more about that in just a few minutes. Now, osteoblasts, again, you can see them. They're lining this area here. That's where they're the bone-forming area there. And here's a scanning electron micrograph of the osteoblast. The maintenance cell for bone is an osteocyte. 90% of the cell is in the mature skeleton. Former osteoblasts are trapped in a new matrix. They maintain bone. They control the concentrations of calcium and phosphorus, and they're directly stimulated by calcitonin and inhibited by PTH. So osteocytes have receptors for both of these main hormones, and we'll talk more in that section of this talk as well. Again, you can see an osteocyte surrounded by matrix. Osteoclasts, they're the bone resorption cell. They're multinucleated, irregularly shaped, and they originate from monocytes. That's another favorite question again. What are the precursors of osteoclast cells? And they're monocytes in the surrounding circulation. Ruffled border, that's the border of the osteoclast, which increases surface area for resorption. There are some questions that come up on ruffled border, particularly with osteopetrosis, and we'll talk about that later on as well. And bone resorption occurs at Hauschup's lacunae. Bone formation and resorption are always coupled. Osteoclasts synthesize tartrate-resistant acid phosphatase. That's the enzyme that breaks down the osteoid, or the minerals, so that you can break down the osteoid. It binds to bone surface via bone anchoring proteins called integrins, and it possesses specific receptors for calcitonin, which inhibits bone resorption. It does not possess specific receptors for PTH, but is activated by a secondary messenger sent by osteoblasts. They're responsible for bone resorption in multiple myeloma and metastatic bone disease. IL-1, this has come up this last 2 years on the OITE, so it's going to be game for the next boards, but IL-1 is a potent stimulator for osteoclastic bone resorption. It's been found in membranes surrounding loose total joint arthroplasties, and it may have a direct role in osteoarthritis. That's Howship's lacunae right there. You can see that it's a multinucleated giant cell that causes resorption, and you can see the area of resorption at the leading edge, and that's the ruffled border edge. Osteoprogenitor cells are precursors of osteoblasts. They're mesenchymal cells that line the Haversian canals and end osteum. They differentiate after receiving an appropriate stimulus. So these cells are, this is our target for a lot of these osteoinductive bone grafting substitutes and so forth we're developing as we're trying to manipulate these osteoprogenitor cells. Bone matrix, organic components 40%, inorganic component is 60%. The organic component is composed of collagen, proteoglycans, non-collagenous matrix proteins, growth factors, and cytokines. Now let's talk a little bit about each one of those. Collagen provides the tensile strength of bone. This should be a review for you all. Type 1 collagen makes up bone. It's 90% of the organic matrix. It's formed by a it's composed of a triple helix. Mineral deposition occurs in the pores and hole zones, and cross-linking decreases solubility and increases tensile strength. Collagen provides the tensile strength of bone. This is the mineral deposition that occurs in the pores and holes. Just take a quick look at that. But here's an electron micrograph of bone collagen. You can see how well-oriented the type 1 collagen is, and that's why you have such good tensile strength. Proteoglycans provide the compressive strength of bone. It's composed of glycan protein complexes, and again, compressive strength of bone is proteoglycans as opposed to the tensile strength, which is collagen. Matrix proteins promote mineralization in bone formation. Osteocalcin, osteonectin, and osteopontin are frequently asked. We don't specifically know how they work, but we know what they do, and they're involved with the last stages of bone formation, the mineralization portion. Osteocalcin is produced by osteoblasts. It's the most abundant non-collagenous matrix protein. It regulates bone density, attracts osteoclasts. It's inhibited by PTH, stimulated by vitamin D, can be measured in the serum or urine as a marker of bone turnover. Again, you don't need to know much of the specifics, but it's involved with the mineralization and promotion of bone formation. Osteonectin is secreted by platelets and osteoblasts. It's also involved with matrix mineralization, and osteopontin is a cell-binding protein. A lot of these, again, for completeness sake, but the very small chance that they're going to be asked. Cytokines and growth factors, this is becoming more and more frequently tested. They're present in small amounts. They're involved in cell differentiation, activation, growth, and turnover. The ones that you commonly hear about are TGF-beta, insulin growth factor, platelet-derived growth factor, IL-1, 6, and BMP. The ones that have been most frequently asked in the last few years are IL-1 and BMP. Now, the inorganic component of bone is this. It provides 60% of the dry weight of bone. Calcium hydroxyapatite is the inorganic component of bone. It provides, along with the proteoglycans, the compressive strength of bone. This may be hard to believe, but in my boards, they ask the formula for calcium hydroxyapatite. So, know it. Bone remodeling, it's modulated by systemic hormones and local hormones, and it's affected by stress, as we mentioned before, Wolff's Law. There's different ways of bone remodeling. Cortical bone is remodeling through an osteoclastic tunneling mechanism. You have the osteoclasts essentially create a path for vascularity that follows. Then osteoblasts and osteoprogenitor cells follow come with the vessels, and then you get bone remodeling. Here's an EM of an osteoclastic cutting cone. All right. Bone circulation, 5 to 10% of the cardiac output goes to the bone. That's important in states such as Paget disease, where you can get significant increase in your bone circulation and you can get high output cardiac failure. But there's three sources to the long bones. There's a nutrient artery system, there's a metaphyseal epiphyseal system, and there's a periosteal system. The bone is very vascularized, as all of you are familiar with. There's a dye study showing just how vascular the bone is. Implications, obviously, are in trauma and in non-unions when you don't have adequate vascularity to allow for healing. The nutrient artery system originates from the major arteries. It enters the diaphysis through the nutrient foramen. Remember that picture there, and it enters the medullary canal. It supplies at least 2/3 of the cortex, and it's a very high-pressure system compared to the periosteal system. Obviously, if you're reaming a femur, you're going to impact the nutrient artery system. Bone circulation, the second type, is at the metaphyseal epiphyseal system. It arises from periarticular vascular plexus, critical for when you have physeal injuries. And the periosteal system is primarily capillaries. It's low pressure, and it supplies the outer third of the diaphyseal cortex. Blood flow and fracture healing. It delivers nutrients to the site of the fracture. Initial response is you have a decrease in flow. It reaches its peak at 2 weeks, and it returns to normal in 3 to 5 months. It's the major determinant of fracture healing, as you all are aware of. Let's look a little more at the biology of bone. The tissue surrounding bone, periosteum, is a tough connective tissue membrane that surrounds bone. It's very highly developed in children. That's why we can get away. It's a very thick layer. That's why we can get away with reducing both bone forearms, and it maintains their position in children as opposed to adults. It's responsible for the growth of bone diameter, and the inner cambium layer is the one that the osteoprogenitor cells are present. It's very vascularized. It contains osteoblastic progenitor cells, and it's responsible for appositional growth, or bone diameter, as well as periosteocallus and fracture healing, is from the periosteal layer. Bone marrow is the source of osteoprogenitor cells. You should be familiar with this. Red marrow is hematopoietic. It's composed mainly of water and fat. Inactive marrow is yellow marrow, and it's significantly more fatty tissue or adipose tissue. All right, take a break here. Everyone okay? You know all this stuff already, right? Please wake up. I know it's 7:30, but those of you who know my partner, Dr. Miller, he's a very energetic. He's always, everything needs to be done 2 days ago. He's an incredibly stressful individual to be around. He has to wear his cool, so maybe he is this stressful because who knows where that thing's going. All right, let's talk about bone formation. Enchondral or endochondral, intramembranous, and appositional. 3 types of bone formation. You have to know these. You already know these. Let's talk a little bit more about the details. Enchondral, bone replaces a cartilage model. Cartilage is not converted to bone. This is a misconception. Examples: embryonic long bone formation, longitudinal growth at the physis, fracture callus, and DMB matrix-enhanced bone formation. That has been asked before. Demineralized bone matrix. What's the how is bone formed when you add this to a non-union? And it's through enchondral ossification. In embryonic long bone, there are a couple embryonic questions. This is what you need to know. There's a mesenchymal onlog at 6 weeks. There's vascular buds that invade the mesenchymal model and bring osteoprogenitor cells. The cell differentiates into osteoblasts and form the primary center of ossification at 8 weeks. The secondary center of ossification develops at the bone ends, and the cartilage model grows by apposition and interstitial growth, bone replacing cartilage. This is what occurs at the physis. We'll talk specifically about the physis now. So, again, here's your onlog, and here's your primary center of ossification, your nutrient artery. So everyone has read Brighton's article, Carl Brighton's article on the physis. The questions that they ask on the physis are very straightforward, but you need to memorize them. So let's just review that very quickly. Horizontal growth plate, is the physis. You have the spherical growth plate, which is the epiphysis. Both have the same arrangement, but the spherical physis is less organized, and they're divided into zones. Everyone remembers this, right? Reserve, proliferative, hypertrophic, and metaphysis. Okay? Majority of the questions that get asked, and these are test-taking tips because obviously can't remember everything. If they ask you, this disease has an abnormality in what zone? If you have no idea, guess hypertrophic zone, because that's the majority of the test questions. The hypertrophic zone is divided into the zone of maturation, zone of degeneration, and zone of provisional calcification. What happens in the reserve zone? You have matrix production. You get essentially, it's the reserve zone. You're essentially building up material for proliferation and differentiation. So cells store lipids, glycoproteins, proteoglycans for later growth. It's a low oxygen tension. Then the proliferative zone is next. That's where you get the longitudinal growth, where the chondrocytes arrange in columns, and the top cell is the dividing cell, and the high oxygen tensions actually inhibit calcification. You don't want calcification early on because you need division. So division occurs in this zone in proliferation and matrix production. That's why it's called the proliferative zone. Now, hypertrophic zone is divided into 3 zones: maturation, degeneration, and provisional calcification. In this zone, that cells obviously hypertrophy. That's why it's called the hypertrophic zone. They increase in size, accumulate calcium, and then they die. The osteoblasts migrate from vessels located in the metaphysis and use the cartilage as a scaffold to lay down bone. It doesn't replace the cartilage, or it actually uses the cartilage as a scaffold. The osteoprogenitor cells use this. The vessel ingrowth occurs, and then you get osteoid put down. So the metaphysis is adjacent to the physis. The osteoblasts use the cartilage scaffold. Primary spongiosa is mineralized to form woven bone first, and then remodeled to form secondary spongiosa according to stress. This is, again, just for your information. Look at this briefly. You have the arrangement and the level oxygen tensions, as well as an initial storage and then depletion. But just look at that briefly. Don't spend too much time. The periphery of the physis, these two, you should know these 2 terms. Groove of Ranvier supplies chondrocytes to the periphery that allows lateral growth or appositional growth, and the perichondral ring of Lacroix is a dense fibrous tissue which anchors and supports the physis. This has implications in severe physeal injuries. There are paracrine and autocrine influences on the growth plate, as well as endocrine influence. This, again, is for completeness. Don't memorize this chart, but just know that there are a pretty extensive influence by hormones and on the growth plate. This is actually the most important slide in this portion of the talk, is the physeal abnormalities. If in the reserve zone, there's abnormalities in Gaucher's, pseudoachondroplasia, dystrophic dwarfism. In the proliferative zone, achondroplasia occurs. There's abnormalities in this zone seen in these disease entities. But you can see the majority of them are in the hypertrophic zone. Rickets, which we'll talk about briefly, enchondromas, some of the mucopolysaccharidoses, scyphes, as well as physeal fractures. Now, physeal fractures occur through the zone of provisional calcification. Just remember hypertrophic zone if you have to guess. All right, let's take a break again. I guess this is the diamond industry. My brother-in-law just got married, so I showed him, or just got engaged, so I showed him this. All right, intramembranous ossification. This occurs without a cartilage model. That's the difference between enchondral and intramembranous. You have undifferentiated mesenchymal cells that aggregate into layers and differentiate into osteoblasts. Okay, these osteoblasts deposit matrix, which is later mineralized to bone. This occurs in embryonic flat bone formations, such as the pelvis and clavicle. Occurs in distraction osteogenesis when you do limb lengthening with Elizaroff, and in young children with amputations at the distal aspect of the amputation site. You can get that cap or blastema bone. That's all intramembranous ossification. Appositional ossification, these are osteoblasts that align on the existing bone surface and lay down new bone. This is increasing bone in width. This is through the periosteum, the periosteal bone enlargement, and this remodels under stress, according to stress as well. The appositional ossification occurs through the periosteum where the osteoprogenitor cells are, as I mentioned briefly. All right, little Redskins trivia. Who's this? Speak up. Who? Oh. Yes, thank you. Sonny Jurgensen. All right. Who's this? Who's this? Which two of these won Super Bowls? There's a former Redskins here. He should know this, right? Williams and Rippon. Good. All right. Who's this? How did his career end? Everyone knows that. Lawrence Taylor, right. Which brings us to our next topic, bone injury, fractures, and repair. So fracture repair. It's a continuum of events. Inflammation, soft callus formation, hard callus formation, and remodeling. Similar to any injury in the musculoskeletal system, same stages. What happens during the inflammation stage? Bleeding at the fracture site creates a fibrin clot. It's the source of hematopoietic cells and growth factors. You get fibroblasts, mesenchymal cells, osteoprogenitor cells, which migrate to the site of initial granulation tissue and then subsequently differentiate to bone under the ideal conditions. Repair, primary callus occurs within 2 weeks. Everyone's familiar with this. Bridging soft callus forms between the bone ends is converted to hard callus by end-chondral ossification. Remember, fracture healing occurs through end-chondral ossification in a normal environment. Obviously, when you're putting plates on fractures, you have a different form of bone healing, and we'll talk about in just a second. Medullary callus supplements bridging callus at a slower rate. The amount of callus formation is indirectly proportional to the amount of immobilization of the fracture. If you have a fracture that's not well mobilized, you're going to have increased callus formation. If you have a fracture that's very well rigidly fixed, you're going to have minimal callus formation. Obviously, if you have too much strain across the callus during healing, you're going to end up with a pseudoarthrosis. You're going to end up with persistence of cartilage rather than conversion to bone. And we'll speak about that in just a minute. So primary cortical healing occurs with rigid immobilization or plate fixation, and it resembles normal remodeling. It occurs through sort of a cutting cone technique. It's called Haversian remodeling, and there's no visible callus. So types of fracture healing based on stabilization. You have in cast immobilization, you have periosteal bridging callus and chondral ossification. Know this slide here. In compression plating, you have primary bone healing. It's a cutting cone remodeling, or Haversian remodeling is what it's also called. This was on last year's OITE. Intramedullary nailing, early on you get periosteal callus, so you'll see some callus formation at the fracture site, but you also have medullary callus formation, and that occurs through endochondral ossification. External fixation, if you don't have a rigid external fixation, you get periosteal and chondral ossification and callus formation. If it's very rigid, you can get primary bone healing. And we'll spend a lot of time talking about external fixation in the biomechanics section. When you have inadequate immobilization, you get a hypertrophic non-union. That's failed end-chondral ossification. That means you have persistence of type 2 collagen, which is seen in cartilage. And you don't have the conversion to type 1 collagen. Remodeling starts at about 2 weeks and continues well after the fracture is healed. Bone assumes its normal shape again based on Wolff's law, the stress it experiences. Woven bone, remember, woven bone is seen in pathologic states such as fractures and infections, and it's replaced with lamellar bone with time. Fracture healing is considered complete when you repopulate the marrow space. They love biochemistry. They love asking you what types of collagen are involved in different stages of fracture healing. This is sort of should make sense and very clear. When you have the mesenchymal stage, you have all the collagens are present. Then in chondral ossification, cartilage is first, right? So cartilage is type 2 collagen, right? So you have a predominance of type 2 collagen. When you get the conversion to chondroid to osteoid, you have type 1, which is in bone. You have persistence of type 2, obviously, that's being used as a scaffold. And the one they ask every year is type 10 collagen. What does type 10 collagen do? It mineralizes. It's involved in mineralization. In the last stages of enchondral ossification, it's involved in the mineralization portion of bone healing. You have to know that one. And then when you are finally healed, it's all collagen type 1, which is seen in bone. BMP is becoming more and more commonly asked as well. Bone morphogenetic protein, or OP1, or it's osteoinductive. It causes mesenchymal cell differentiation to osteoblasts. This is how we're trying to manipulate fracture healing. The target cell for BMP is undifferentiated mesenchymal cells, and we are having some success with this, particularly in spinal fusions and non-unions of long bones. Of course, spinal fusions doesn't matter because spine surgery doesn't work, right? Sorry, Case. All right, transforming growth factor beta induces this is another one that you should be familiar with. Again, the BMP is the main one, but transforming growth factor beta induces mesenchymal cells to produce type 2 collagen and proteoglycans. It is present in fractured callus. It regulates cartilage and bone formation in fractured callus. It's more involved in the early stages of bone formation. That's why we're trying to use insulin growth factor in the early stages, trying to get some of these fractures to heal. It's more in the cartilaginous portion. It stimulates that was transforming growth factor. Insulin growth factor is involved in stimulating type 1 collagen. It's cellular proliferation. We don't know how a lot of these work. That's why we haven't been able to figure out how to get all non-unions to heal yet, but we are making progress. But this is one of the other factors that's being used, and we're trying to add these growth factors at the right time to manipulate these cells to differentiate into osteoblasts in bone-forming cells. Platelet-derived growth factor is involved in the very early portions or the inflammatory stage where they're released from platelets. They're chemotactic and they're felt to attract the osteoprogenitor cells to the injury site. Let's talk a little bit about bone grafting. You have to know the difference between osteoconductive and osteoinductive, which I'm sure you're familiar with. Osteoconductive, some definitions here. What graft properties? They can be either osteoconductive, where they're a scaffold or framework for which bone growth occurs. They can be osteoinductive, growth factors such as BMP, transforming growth factors. They all promote bone formation. Osteogenic cells are mesenchymal cells, osteoblasts, and osteocytes. These cells, they're present at the fracture site often, and we're adding factors to try to get them to differentiate. And then we'll talk about structural integrity as well of graft properties. So a few definitions. You have autografts and allografts. There's different types of allografts. You have fresh, which have increased antigenicity. You have fresh frozen, which are less immunogenic, and BMP is preserved. Freeze-dried, you lose your structural integrity and you deplete the BMP. They're the least immunogenic, but they're osteoconductive. Demineralized bone matrix, or graft-on, is osteoconductive and osteoinductive. And there's a chart that's in your next few slides, which you should be familiar with. So the cells that incite the greatest immunogenic response compared to the other constituents are the bone marrow cells, and that should make sense. The least immunogenic is going to be the hydroxyapatite, or the mineral. Types of bone graft: cancellous bone, cortical bone grafts, osteochondral bone grafts, and vascularized bone grafts. Cortical bone grafts incorporate slowly. The remodeling occurs via resorption followed by deposition of new bone. They're weak during the resorption phase. Those of you who are doing fibular grafts or have done vascularized fibular grafts or strut grafts, they resorb and you get fatigue fractures with time, and that's because the incorporation occurs with initial resorption of the graft. Cancellous bone graft is actually revascularized quickly. Osteoblasts are laid down on the new bone, lay down new bone on the old trabeculi of the cancellous bone graft, and this is through a process of creeping substitution. This has been asked over and over again as well. Creeping substitution occurs in avascular necrosis as well, so we'll talk about that too, but be familiar with that term. The process of bone formation in cancellous bone grafting is creeping substitution. Synthetic bone grafts are becoming very popular: calcium, silicone, and aluminum. If you look at all these types, what do they all have in common? They're all osteoconductive. None of these grafts are osteoinductive. Again, the bone graft, comparing the different grafts and their osteoconductive and osteoinductive capability. Cancellous autografts are the best in terms of osteoconduction and osteoinduction. Cortical is fair, but look at demineralized bone matrix here. This is the only synthetic graft that, or this is the only graft substitute that we have that has fair osteoconduction and good osteoinduction. Just factoids, really, for heterotopic ossification. Ectopic bone forms in response to injury. You get myositis is HO in the muscle. It's common in closed head injuries, total hip arthroplasty, and Paget's. What's the optimal time for resection is debatable. What does irradiation do? It prevents proliferation and differentiation of mesenchymal cells. So that's why people who have heterotopic ossification resection, or they're at high risk for HO after injuries, particularly around the elbow or the hip, irradiation prevents the differentiation of mesenchymal cells to osteoblastic or osteogenic cells. These diphosphonates that are used inhibit mineralization, but once you stop giving these, but they still allow for osteoid formation. So once you stop giving these agents, the osteoid's already there. It just mineralizes. So it's not a true treatment for HO or a long-standing treatment for HO. All right. This is a tough topic here, and I'll try to go through it fairly slowly just so that you guys are clear. Now, there's no way in half an hour I'm going to be able to explain the details of normal bone metabolism and abnormalities in bone metabolism. The questions that you see are, they'll give you a bunch, the question will have a bunch of lab values and say, what does this person have? Every one of these questions has a tip-off where you don't even have to know what you're talking about, but you can get the question right. It helps to know a little bit, obviously, the basics of bone metabolism, but there's very clear tip-offs on these questions that I want you to be familiar with as well. You have to be an endocrinologist, really, to understand all of normal bone metabolism and the abnormalities that we'll see, but let's cover these very quickly here. Normal bone metabolism, all of these hormones and so forth are involved with normal bone metabolism. It's an incredibly complex system. Calcium is, bone is a reserve for 99% of bone's calcium. It's important for muscle and nerve functioning and the clotting mechanism. Plasma calcium is 1%. 50% is free, 50% is bound to albumin. Calcium is absorbed in the duodenum by active transport. That's regulated by 125 vitamin D, or the active form of vitamin D, and by passive transport in the jejunum, and it's resorbed in the proximal tubules of the kidney. What are the dietary requirements? Remember, lactating women have the highest dietary requirement. Postmenopausal women have high requirements as well. But just have an idea, this has shown up before, who has the highest requirements for dietary requirements for calcium. What are the primary regulators of calcium? Now let's make sure we understand this, because it makes a lot more sense if you understand what these two agents do. PTH, if you have low calcium, PTH is released. Its response is to put more calcium into the plasma, right? It acts on osteoblasts through a secondary messenger from osteoblasts, which I've mentioned before, and it increases the level of calcium. Okay? What does it do to phosphorus? It actually decreases the level of phosphorus. So so if you have it increases calcium, decreases phosphorus. What does vitamin D do? The active form of vitamin D. It increases calcium and increases phosphorus. Okay? So take a second, put that in the memory bank, because the rest of this section, it's very important to realize that. So phosphate, what is 85% of the body stores in bone? Plasma phosphate is unbound and is resorbed in the proximal tubules of the kidney. Remember, calcium and phosphate are both resorbed in the kidneys. Calcium is also resorbed in the GI tract. Dietary requirement is listed. Again, there's several. It's a very complex cascade. You have the GI tract. You have the proximal tubules of the kidney, the bone, the thyroid, and the parathyroids all interact to determine your extracellular fluid levels of calcium and phosphate. There's a biofeedback. There's a feedback, negative feedback mechanism, positive feedback mechanism, and that's how you get the answers to these questions right, if you understand that. So parathyroid hormone secreted from the chief cells of the 4 parathyroid glands. It regulates plasma calcium, increases plasma calcium, right? Decreases plasma phosphate. It directly activates osteoblasts, which stimulate osteoclasts through a secondary messenger. It modulates renal phosphate filtration. Decreased calcium levels stimulate PTH release, which acts at the intestines, kidney, and bone, right? So if you have low levels of calcium, your body's going to say, we need to put more calcium into the plasma. Your parathyroid glands are going to increase their PTH secretion. Vitamin D, it's a naturally occurring steroid activated by irradiation from sunlight or for dietary intake. We don't really have too many problems with vitamin D deficient rickets now, which is another topic a little bit later on, because vitamin D is in our milk, but you still see it. But vitamin D is very integral in the calcium and phosphate minerals metabolism. It's hydroxylated in the liver to 25-hydroxycholecalciferol or vitamin D, and it's hydroxylated again in the kidney to either the active form, which is 125, or the inactive form, which is 2425. Now this chart, put this into memory here. So in the liver, you have 25 vitamin D, and then it gets activated into, it either forms the active form or the inactive form in the kidney. Now this should make sense. If you have high PTH and vitamin D work together to increase calcium levels. So if you have low calcium, it should make sense. You should get the active form of vitamin D, right? Now, if you have low phosphate, remember, vitamin D wants to increase phosphate and calcium. So if you have low phosphate, it's going to want to form the active form of vitamin D as well. And high PTH, if you have a high level of PTH, that means you have a low level of calcium. So that's going to, again, work in concert. High levels of PTH cause this 1-alpha hydroxylase. It activates the 1-alpha hydroxylate enzyme in the kidney to form the active form of vitamin D. The inactive form of vitamin D occurs when you already have high levels of calcium. You don't need more vitamin D. Your calcium levels are normal or high levels of phosphate, or you have low levels of PTH. So this should make complete sense why you get the when you should get the active form and when you get the inactive form. There are pathologic states where the 1-alpha hydroxylase enzyme is abnormal or does not work, and you end up getting you don't end up getting the active form of vitamin D, and we'll touch on that in just a minute. So the active form works on the intestines, kidneys, and bone. Again, it increases serum calcium and increases serum phosphate. PTH increases serum calcium and decreases serum phosphate. Dilantin has been shown to impair the metabolism of vitamin D, and that's why patients have problems with calcium mineral metabolism when they're on these agents. Again, we talked about vitamin D. Know where the transformations occur. The first transformation of vitamin D is in the liver, and the second is in the intestines, and then the active and inactive form are formed, and the active form acts on the kidneys, intestines, and at the level of the bone. What's calcitonin? It's made by clear cells. Remember, PTH was made by the chief cells of the parathyroid. The reason I'm saying this again, because this was tested. And calcitonin is made by the clear cells in the parafollicles of the thyroid gland. The main effect is inhibition of osteoclastic bone resorption. Calcitonin acts directly on osteoclasts to decrease serum calcium levels. It prevents bone resorption occurring. So calcitonin release is stimulated by high levels of calcium, the opposite of PTH. And it's a target for osteoporosis treatment. Activating calcitonin prevents bone resorption, or activating the calcitonin receptor on osteoclasts prevents bone resorption. Estrogen, now this is debatable. There's a section on osteoporosis a little bit later on where I'll touch on some of the more recent studies that have come out. But estrogen prevents bone loss by inhibiting bone resorption. As I mentioned before, osteoclasts and osteoblasts have receptors for estrogen. Bone formation and resorption are coupled, so estrogen actually decreases bone formation as well as bone resorption. It just does bone resorption at a slower rate, so you end up having less problems with osteoporosis, but it only works in postmenopausal women if it started within the first 5 to 10 years. If you wait too long, then it doesn't have an effect. This is very controversial about combining it with progesterone therapy because of the recent Women's Health Initiative study, and I don't suspect they'll ask you anything on estrogen or hormone supplementation for osteoporosis because of the recent controversies. Several hormones are involved in mineral metabolism, corticosteroids, thyroid hormones, growth hormones. They're not going to ask you any specifics on this. This is just for completeness. The main ones they ask you from year to year are PTH, and calcitonin, and vitamin D. When do you reach your peak bone loss? All of us have already passed it. 16 to 25 years. It decreases 0.3 to 0.5% a year, and then decreases 2 to 3% a year for untreated women during first 6 to 10 years after menopause. So that's why you need to institute hormonal therapy, or that's why the thought was that hormonal therapy needed to be instituted early on. Again, osteoporosis, there's a section on this, but it occurs at the onset of menopause. Markers of bone resorption are urinary hydroxyproline and peritidine crosslinks. Markers of bone formation are serum alkaline phosphatase. Remember, bone formation is always coupled with resorption, so you have levels, elevated levels of these markers. I'm sure you guys feel like this. All right, I find this funny. Any bald guys here would also, but heart transplant isn't worth much if he doesn't look good. Let's give him a hair transplant too. You guys you guys must be hungover. I mean, come on. I've gotten some laughs out of this cartoon in the past. All right, conditions of bone mineralization. Now, we talked about normal mineral metabolism. Now, let's talk about the abnormalities, and this is where they like to ask questions. Hypercalcemic disorders, hypocalcemic disorders, and hypophosphatasia. Hypercalcemia, presenting signs and symptoms. You have polyuria, kidney stones, osteofibrosis cystica, CNS effects, GI effects, stones, groans, psychiatric overtones. Remember that, right? The differential diagnosis of hypercalcemia is a laundry list. The one we need to be familiar with is hyperparathyroidism. That's the one that's tested. Hypercalcemia from malignancy is also tested, but those are the ones you need to know. The others you don't worry about unless you're an endocrinologist. Primary hyperparathyroidism is the overproduction of PTH by a parathyroid adenoma. So if you have high levels of PTH, what's going to happen to your calcium? It's going to go up, right? So you have a net increase in plasma calcium. So what's going to happen to your phosphate? Say something. Goes down. Good. Decrease in plasma phosphate. You have increased urinary excretion. You have increased osteoclastic resorption because of the high levels of PTH. Thus, you have a net increase in plasma calcium. The diagnosis, again, hypercalcemia, increased serum calcium, PTH, urinary phosphate, right? You're going to be dumping more phosphate into your urine, so you're going to have higher levels of phosphate in your urine, but lower serum levels of phosphate. Here's the labs, and this should all make sense. So if you have high levels of PTH, what happens to your calcium? Goes up. What happens to your 125 vitamin D? Remember that enzyme that gets stimulated by PTH, the 1-alpha hydroxylase? It forms the active form of vitamin D. So 125 is going to go up. 125 is going to go up because PTH is elevated. What's going to happen to the urinary calcium? Urinary calcium also goes up because you have so much excessive serum calcium, you start spilling it into your kidneys. What happens to your phosphate? Go down, right? PTH stimulates vitamin D conversion to the active form of 125. Okay, everyone clear on that? These labs should be very easy. Makes sense. Primary hyperparathyroidism, what do you see? You see osteoblasts and osteoclasts active on both sides of the trabecula. They have wide osteoid seams. What is the treatment? Again, the number one cause of primary hyperparathyroidism is a parathyroid adenoma, so surgical parathyroidectomy is the treatment. Hypercalcemia of malignancy is the other one that they'll test you on. It can be life-threatening, results from a release of systemic growth factors and cytokines that stimulate osteoclastic activity. The most common one is PTH-related protein from oat cell carcinoma of the lung. It can be seen in multiple myeloma as well. Know how to treat this. Hydration, loop diuretics, dialysis, mobilization prevents bone resorption, and then some drug therapies, particularly IV drug therapies, are helpful. Bisphosphonate therapy. Okay, that's hypercalcemia. Hypocalcemia is when you have low PTH or vitamin D. It results in neuromuscular irritability, tetany, seizures. What's Schwartz's sign? Everyone remember? Right? Good. Cataracts, fungal infections, and EKG changes. What's prolonged QT interval called? Someone yell it out. Torsades, right? Torsades. Good. Hypocalcemia. Differential diagnosis. These are the ones you need to be familiar with. Hypocalcemia, the pathologic states. Hypoparathyroidism, pseudohypoparathyroidism, renal osteodystrophy, and rickets. These get very confusing, but I'll try to simplify them as much as possible. Hypoparathyroidism. Decreased PTH. So what's going to happen to your plasma calcium if you don't have enough PTH? It's going to go down. What's going to happen to your plasma phosphate? It's going to go up, right? Because PTH decreases your level of plasma phosphate. Again, common findings. Iatrogenic hypoparathyroidism results from thyroidectomy. That's the #1 cause of hypoparathyroidism. The labs, again, these should make sense. So hypoparathyroidism, PTH is decreased. So what's going to happen to your calcium levels? It's going to be down. It's going to happen to 125. If PTH is low, you don't stimulate that enzyme to form the active form of vitamin D. So the active form of vitamin D is low. Your urinary calcium is going to be low as well because your serum calcium is low. Your serum phosphate will be elevated because you don't have enough PTH, right? PTH decreases serum phosphate. So if you don't have adequate PTH, your serum phosphate levels are high. Does that make sense, guys? It's clear? I mean, they're going to give you these lab values, but if you look at them, they're always intimidating when you first see them. But if you break it down, they're very clear. They're quite easy. Pseudohypoparathyroidism is a rare genetic disorder caused by lack of PTH effect on the target cell. So it's similar to type 2 diabetes, essentially. You have a resistance to PTH. So the PTH levels are there, but they're not acting on the target cell. Albright hereditary osteodystrophy is associated with pseudohypoparathyroidism. Hand surgeons out there, you may diagnose someone with this disorder in your clinic because they have short 1st, 4th, and 5th metacarpals, metatarsals, and other findings. But a hand X-ray, if you see this constellation of findings, they may have an endocrine abnormality. So pseudohypoparathyroidism labs, again, your PTH is normal or increased, so you should expect your calcium to be high, right? It's not because it's not working on the target cell. So your serum calcium is low. If your serum calcium is low, your urinary calcium is going to be low as well. Your 125 vitamin D, which should be stimulated by PTH, is not because, again, there's no effect on the target cell. So your 125 vitamin D is low. And you'll get increased serum phosphate as well because PTH isn't working. So that's pseudohypoparathyroidism. This is an incredibly confusing topic, renal osteodystrophy. And however, the answers on the exam are fairly straightforward. It's a spectrum of disorders in bone metabolism in patients with chronic renal disease. Remember, calcium and phosphate reabsorption occurs in the kidney. So if you have any impaired renal function, it's going to compromise your mineral metabolism. There's 2 types of renal osteodystrophy: high turnover disease, which is due to a chronically related PTH, and there's low turnover disease, which is an excess deposition of aluminum in bone. So it's actually from the treatment with all these antacids, and you end up getting reduced levels of PTH. Do not spend time learning the difference between high turnover and low turnover renal osteodystrophy. The answers are quite easy because this is the only state where you have elevated BUN and creatinine and a low GFR. And those are the labs they're going to give you. Don't spend too much time putting this into the memory bank before the test. But high turnover disease, just for completeness sake, leads to secondary hyperparathyroidism. You have decreased renal phosphorus excretion because of your kidney disease. So if you have high levels of phosphate, what's going to happen to your PTH? Right? PTH wants to decrease phosphate, so your PTH levels are going to go up. So you get phosphorus retention promotes secretion of PTH. You get hyperphosphatemia, phosphorus. So phosphorus, high levels of phosphorus are going to do what to the vitamin D metabolism? Vitamin D increases phosphate levels. You already have high levels of phosphate, so it's going to shut down the active form of vitamin D and is going to give you the inactive form. And again, it's this interplay. You have to understand this interplay between vitamin D and PTH. But increased phosphate is going to provide a positive feedback to PTH, so you're going to get an increase in PTH, a secondary hyperparathyroidism, because of the inability to secrete phosphate. So again, high turnover disease labs, BUN and creatinine are elevated. Okay, this is the giveaway for this abnormality for renal osteodystrophy. But high turnover is determined because you have a secondary hyperparathyroidism, you have high levels of PTH, and high levels of serum phosphate because of the hyperphosphatemia. Treatment is you want to reduce the phosphate load, dietary phosphorus restriction. You can give antacids. You can give 125 vitamin D to try to increase your calcium levels. Ideally, is to correct the renal disease if possible. The low turnover disease there's no secondary hyperparathyroidism. Bone formation or turnover is reduced because of aluminum toxicity. A lot of the antacids and so forth that are using to treat this is a result of treatment. And you can get low turnover disease. So you have a spectrum in renal osteodystrophy. You can either get high or low turnover disease, but the treatment for these are the same. Ideally, you would like to get them, they often are dialyzed, but ideally if you can get a new kidney. Aluminum toxicity, what does aluminum do? It impairs differentiation of precursor cells to osteoblasts. So this is actually acting at the level of the bone. Impairs proliferation of osteoblasts and inhibits the release of PTH, and it disrupts the entire mineralization process. It's most common in chronic renal failure patients. They can get osteomalacia, again, because of the defect in mineralization. So the low turnover disease here, again, BUN and creatinine are going to be abnormal. GFR are going to be increased. GFR is going to be reduced. There is no secondary hyperparathyroidism. So if they ask you what's the difference between low and high turnover disease, PTH is impaired by the aluminum toxicity, so you'll have a normal or low level of PTH, as opposed to the high turnover disease where you have a secondary hyperparathyroidism because of the high levels of phosphate. This is a chart. Again, this is not something that you have to know or commit to memory for the sake of the boards. High BUN and creatinine, low GFR means renal osteodystrophy. Rickets. It's a spectrum of disorders. It's a failure of mineralization. Remember, it's in the zone of provisional calcification, or the hypertrophic zone. Remember, when in doubt, hypertrophic zone. It leads to changes in the physis and cortical bone. The physis has increased width. Bone there's cortical thinning and bowing of the bones. We don't see rickets as much because of the fact of our supplementation in milk. But we do see it in patients from the third world. What are the causes? There's a laundry list of causes of rickets: nutritional deficiency, GI absorption defects, renal tubular defects. Renal osteodystrophy can cause it in young, and then there's many miscellaneous causes. The ones that we need to be most familiar with and we need to understand the labs on, we'll go over now. The nutritional rickets can occur from vitamin D deficiency, calcium deficiency, or phosphate deficiency. Vitamin D deficient rickets. It's rare again in the U.S. after addition of vitamin D to milk. It can be seen in premature infants and in malabsorption syndromes. How do you treat vitamin D deficient rickets should be intuitive. You treat them with vitamin D supplementation. Again, the physeal abnormalities and abnormalities in the hypertrophic zone of the growth plate. The physical exam findings are you get the rachitic rosary or the enlargement of the costocaudal junction, bowing of the knees, delayed bone growth, get pathologic fractures. You can X-rays show physeal widening, cupping, and coxa-vara. Here are the labs, and this should make sense again. So what's going to happen? If you don't have enough vitamin D, both your active and inactive forms and your precursor of vitamin D are going to be low. If all of those are low, what's going to be your serum level of calcium? It's going to be low. What's going to be your serum level of phosphate? Right? Vitamin D increases serum and phosphate, so if vitamin D is low, serum and calcium phosphates are going to be low. So what's going to happen to your PTH level? If your serum calcium is low, your PTH is going to go up, right? All right. So again, this is just to give you a general idea of the response to the labs. They don't always fit into the scheme, but again, for the sake of these questions, these should make sense. Understanding vitamin D and PTH interaction is critical. Calcium deficiency rickets. Hypocalcemia is going to lead to an increase in PTH. Increased PTH forms the active form of vitamin D. So you get excessive resorption of calcium. Or attempt to resorb calcium, but you don't have enough calcium in your body because there's a dietary deficiency of calcium. And it can cause problems in adults, such as osteomalacia. Treatment is oral calcium. So let's go back to the labs here. For this, you have high levels of PTH, high levels of the active form of vitamin D, but because you don't have enough dietary calcium in your body, you're going to have decreased levels of calcium. And you're going to have decreased levels of urinary calcium as well, because there's just low levels of serum calcium to begin with. Treatment is oral calcium. That should make sense. Phosphate deficiency rickets. If you have a decrease in serum phosphate, if you don't have enough phosphate in your nutrition, what's going to happen to your level of vitamin D? It's going to want to go up, right? Because you don't have adequate serum phosphate. There's no secondary hyperparathyroidism or vitamin D deficiency. You have the adequate amount of vitamin D. So what you have here, again, is you'll have your calcium levels may be normal, your PTH levels are going to be normal, your vitamin D, your vitamin D, the active form of vitamin D is going to be high because of your low serum phosphate levels, and you'll have decreased serum phosphate levels. You treat it with oral phosphate. So when you get, again, into the nutritional deficiencies, there's calcium deficiency, there's vitamin D deficiency, and there's phosphate deficiencies. And the labs should make sense, and the treatment should make sense as well. Hereditary vitamin D dependent rickets. This is very commonly tested. The nutritional rickets are not that commonly tested because we don't see it that often. But this is a rare disorder, but of course, they like to ask rare disorders. There's two types. There's type 1 and type 2, and it's similar presentation to vitamin D nutritional deficiency rickets, but it's much worse. Type 1 is termed pseudovitamin D deficiency. There's a defect in the renal hydroxylate, the alpha hydroxylate enzyme, as I mentioned earlier. So you cannot form the active form of vitamin D. The 125 vitamin D does not form because of the abnormality in that enzyme. It's an autosomal recessive disorder. It's been mapped to a chromosome, and treatment is to give the active form of vitamin D. So what are the labs in type 1 pseudovitamin D deficiency? You should have, if you have decreased serum calcium and decreased serum phosphate, your levels of vitamin D, active form of vitamin D, should be elevated, correct? Right? Makes sense? But they're not in this scenario because you don't have the enzyme forming the active form of vitamin D. However, your precursor, your 25 vitamin D, is elevated again because you're not getting, your liver keeps increasing your amounts of 25 vitamin D because it's not getting the feedback that the active form, 125 vitamin D, is being formed. And if you have low levels of serum calcium, what's going to happen to your PTH? It's going to go up, right? So this is the abnormality here. With serum calcium and phosphate both being low, you should have high levels of the active form of vitamin D, and you do not. Type 2, hereditary resistance to vitamin D. This is a defect in the intracellular receptor for 125 vitamin D. So you're forming the active form of vitamin D. It's just not acting on the target cell. So that should tell you right there that that's going to be the difference in the labs between type 1 and type 2. This is a very difficult problem to treat. In type 1, you give them the active form of vitamin D. In type 2, there's no response to the active form of vitamin D. You can give them high doses of vitamin D and calcium, but it's an incredibly difficult problem to treat. So what's the difference in the labs here? Serum calcium and phosphate are decreased, as in type 1 vitamin D, but in type 1, the active form was decreased as well because it wasn't being formed. In this scenario, the active form is elevated, but you should see low levels of the precursor, right? Because there should be a feedback that tells the precursor to decrease the levels of the 25 vitamin D. But the 125, the active form, is not working on the target cell, so your body is not getting the input that you have adequate amount of the active form of vitamin D present, so it's going to keep increasing the precursor for the active form. So you guys is the difference clear between type 1 and type 2? Yes? No? Maybe? Don't give a damn. All right. This is, if you get completely confused on rickets and you see familial hypophosphatemic rickets, answer that, okay? Because this is the most common form of rickets. And this is the one that comes up over and over again. Hopefully, after you review this lecture before the boards, this will be a lot clearer and you won't have any confusion with rickets. But this is also known as vitamin D-resistant rickets and phosphate diabetes. It's an X-linked dominant disorder that results in impaired renal tubular resorption of phosphate. It's, again, the most common form of rickets. Treatment, you give phosphate and vitamin D replacement. You give vitamin D to negate the hypocalcemic effects of phosphate supplementation. But this is, again, an X-linked dominant disorder. You have impaired renal tubular resorption of phosphate, and it results in the following labs. So you have decreased serum phosphate, and you have normal, essentially normal calcium, but you have high levels of normal PTH and 25 vitamin D, but you should have much higher levels of 125 vitamin D in the face of decreased serum phosphate. Levels are normal or low normal, so you should have much higher levels. But this is the most common form of rickets is, again, familial hypophosphatemic rickets. It's an X-linked disorder. Presentation in older people is osteomalacia. In younger, it's rickets. You have multiple deformities. This is a very commonly tested question, and it's the easiest one to get right. Hypophosphatasia. It's an autosomal recessive disorder. There's an inborn error that leads to low levels of alkaline phosphatase, which is required for synthesis of inorganic phosphate. Features are similar to rickets and osteomalacia. The diagnosis is confirmed with increased urinary phosphoethanolamine. We don't know how to treat it, but it's very simple. When you look at the labs, if you have decreased alkaline phosphatase, the answer is hypophosphatasia. Next question, okay? This is the one. This is a giveaway. As I told you, most of these questions, even if you don't quite have a grasp on all of the mineral metabolism, there's some tip-offs, and they like to ask these questions over and over again. Hypophosphatasia is an inborn error that leads to low levels of alkaline phosphatase. It's the only one that does. Okay. You guys probably feel like this right now, right? All right. This gets a little bit easier, and then we're going to go over quite a few questions. And then we'll take a few-minute break. So decreased bone mineral density and increased bone mineral density states, as well as both. Osteopenia is decreased bone mineral density. When do you see that? Osteoporosis, osteomalacia. For some reason, they occasionally like scurvy questions, even though we never see it here. There's marrow packing disorders such as myeloma and leukemia, and then osteogenesis imperfecta. So osteoporosis, again, age-related decrease in bone mass, seen in postmenopausal women, 1 million fractures per year. It's a quantitative, not qualitative defect in bone. The bone is normal. It's just a quantitative defect. Risk factors are listed. Everyone is familiar with sedentary lifestyle, a thin person, Northern European descent, smokers, drinkers, dilantin use. Cancellous bone is most affected. There's 2 determinants in the development of osteoporosis. This was on the OITEs 2 years ago. Peak bone mass and rate of bone loss thereafter are the 2 determinants in the development of osteoporosis. The rate of bone loss is a result of normal aging process. It's accelerated with menopause in females, and there's several genetic and environmental influences. There's 2 types of osteoporosis which you should be familiar with. Type 1 is postmenopausal. It affects the trabecular bone. Vertebral and distal raised fractures are common. Type 2 is age-related or senile osteoporosis. It affects men and women. It's old patients older than 75. Hip and pelvis fractures are common. It affects both trabecular and cortical bone. Clinical features we're all familiar with. This is what keeps us in business. What are the lab studies of osteoporosis? Lab studies are normal. Radiographs are only helpful if there's greater than 30% bone loss. DEXA is a very accurate diagnostic tool. That's still the answer right now, although there's other ways to test. Histology is thinning of trabeculi, decreased size of osteons, enlargement of eversion in marrow spaces. So this is an example of an individual at 23 years of age, 63 and 89, and you can see the effect on cancellous bone. So it's a quantitative defect, not a qualitative defect. So DEXA is used for bone mass measurements in the central skeleton. They like questions on T-scores and Z-scores, so we're going to spend a few seconds on this. Bone mineral content varies with age, sex, and race. Bone mineral content is determined with your DEXA. You need a normative database, which is necessary when reporting bone mineral content. So what are the definitions of these? This used to confuse me, but hopefully this will make a little more sense now. But Z-score is a measure of the patient's results as a deviation from the mean of age-matched controls divided by the standard deviation of this mean. So a Z-score is taking a person and comparing it to people of their same age group, okay? So if you have some abnormality, a mineral metabolism abnormality, that's picked up by the Z-score. Hyperparathyroidism, so forth, something along those lines, that can be picked up by the Z-score. You're being compared by people in your own age group. The T-score is what you're going to be asked about, and that's the bone density of a patient compared to peak bone mass of young and normal adults, and you give the patient's results as a deviation from the mean of a young normal adults divided by the standard deviation of the mean. So how do you interpret? What are the T-scores? Normal. Bone mineral content is not more than 1 standard deviation below the average value of young adults. Osteopenia, the definition of osteopenia is low bone mass. Bone mineral content is between 1 to 2.5 standard deviations below young adult average. Osteoporosis, definition of osteoporosis is bone mineral content more than 2.5 standard deviations below a young adult average. That's a T-score of 2.5 or greater. And then severe osteoporosis is bone mineral content greater than 2.5 standard deviations plus an insufficiency fracture. And these are the World Health Organization guidelines on how to interpret T-scores. Put this to memory. So how do you treat osteoporosis? Obviously there's a lot of effort being put from a research standpoint in the treatment of osteoporosis. Physical activity is important. There's a big focus on preventative medicine, calcium, vitamin D supplementation. There's bisphosphonates that are used. How do bisphosphonates work? They inhibit the osteoclastic membrane ruffle border without destroying the cells, so they prevent resorption, osteoclastic resorption. Avista is becoming more common. It's an estrogen receptor modulator. Estrogen is important because it inhibits bone resorption or slows down bone resorption. Recombinant PTH is also becoming more popular. I don't think it's going to be tested at this point, maybe in a couple more years. Forteo is the name of the drug. This makes no sense to me at all. You get a pulsatile release of PTH. PTH, what does PTH do? It causes resorption of calcium, so how can it be used in osteoporosis treatment? My wife is an endocrinologist. I asked her the same question. They have no idea how it works. But for some reason, the pulsatile release of PTH preserves maintains the high level of bone mineral content. Calcitonin has been used, but not that great long-term effects. Combination therapies are also present, but estrogen and progesterone therapy is less common since this recent women's study, so I don't think this is going to be tested anymore. So don't expect to get a hormonal supplementation question for osteoporosis. Again, preventative medicine is the key. Prophylaxis, diet with adequate calcium and vitamin D. Weight-bearing exercise program is critical. When do you treat for osteoporosis? This has been asked as well. It's a little bit controversial, but you want to have a T-score 2.5 or greater. So the true definition of osteoporosis is when you start treating for osteoporosis. Not preventative. You can still give someone vitamin D, calcium, weight-bearing exercises, but true treatment for osteoporosis. When you have a T-score greater than 2.5, any osteoporotic fracture, there's no indication at this time to treat for osteopenia with a lot of these agents, such as bisphosphonates and so forth. Again, osteopenia is defined as less than 2.5 standard deviation T-score. What agents, if they ask you a question, calcium and vitamin D is supplementation is important. It should be an answer to everyone. And then bisphosphonate therapy should be the first-line treatment if they ask you a question for treatment of osteoporosis. Osteomalacia is a defect in mineralization. It's a failure to maintain serum calcium and phosphate levels. You have unmineralized osteoid. It's a qualitative defect. You have plenty of osteoid. This is the difference between osteoporosis and osteomalacia. Osteomalacia is a qualitative defect. Osteoporosis is a quantitative defect. Vitamin D deficient diets, GI disorders, renal osteodystrophy. Certain drugs impair your mineral metabolism and can result in osteomalacia. It's seen in alcoholics. X-ray findings, biopsy is required for diagnosis. You have widened osteoid seams. How do you treat? You give large doses of vitamin D. Again, put this chart to memory here, comparing osteoporosis to osteomalacia. This has been asked as well. Bone mass is decreased in osteoporosis. Bone mass can be quite variable in osteomalacia. Mineralization is normal in osteoporosis. It's decreased in osteomalacia. Osteoporosis is seen in the elderly population. Osteomalacia is seen at any age. Osteoporosis can be either senile or postmenopausal. Lab findings in osteoporosis are normal, whereas lab findings in osteomalacia are abnormal. Scurvy, just because it's come up. Vitamin C deficiency. It's a decrease in chondroitin sulfate synthesis, which results in defective collagen growth and repair. You have impaired intracellular hydroxylation of collagen peptides. You don't get normal cross-linking of your collagen peptides. Clinical features are fatigue, bleeding gums, and joint effusions. Remember, it's the sailor who they treated it with oranges in the past. Give him some vitamin C. X-rays are thin cortices, metaphyseal clefts. Labs are normal. Histology, you get granulation tissue in widened zones in the provisional zone of calcification in the physis, again in the hypertrophic zone. The greatest effect is on bone formation in the metaphyseal region. Treat with vitamin C supplementation. Osteogenesis imperfecta, you have abnormal collagen synthesis. This will likely be covered in other lectures as well. But it's a mutation in the gene responsible for producing type 1 collagen. This was last asked on the OITEs 2 years ago. So type 1 collagen defect. Again, you have multiple fractures, bowing of the bones. A couple increased osteodensity states. The most commonly asked is osteopetrosis or marble bone disease. Osteopoikilosis has been asked as well, and Paget's, which I'm sure Dr. Parsons covered yesterday. So osteopetrosis is increased sclerosis and obliteration of the medullary canal. It's due to decreased osteoclast function. Histologically, osteoclasts lack the normal ruffled border. They love ruffled border questions, right? Bisphosphonates act on the ruffled border. Osteopetrosis is an abnormality of the ruffled border or the osteoclast ability to resorb bone. So marrow becomes filled with necrotic calcified cartilage. There's two types. There's an infantile malignant form, which is severe. You get hepatosplenomegaly, aplastic anemia, usually results in death unless a bone marrow transplant is performed. The more benign form is Albrecht-Schoenberg disease, which is generalized osteopetrosis and sclerosis. Your bone quality, even though it's thick, it's not normal, so your bone fractures. Has anyone tried to fix a person, nail a femur with osteopetrosis? It's unbelievable. You can't believe they fractured their femur, but you break every drill bit when you try to ream their medullary canal. The bone is thick, but it's not normal. So it's a very brittle bone, but they're very difficult fractures to treat, particularly in the long bones. You can see this calcified cartilage that retained, and there's how dense the bone can be. Osteopoikilosis or spotted bone disease are just bone islands. They're islands of deep cortical bone which appear within the medullary canal of long bones. They're asymptomatic. There's no incidence of clinical or malignant degeneration. These are just benign bone islands. Paget's disease, I know Dr. Parsons touched on. There's two phases, active and inactive phase. You have elevated serum alkaline phosphatase and urinary hydroxyproline. In the active phase, you can have intense osteoclastic bone resorption, mixed phase, and then you can have a sclerotic phase where you have osteoblastic bone formation that predominates. The key on histology is you have bone in various stages of repair, or you have woven bone, you have lamellar bone, you have both types of bone in Paget's disease. Obviously, if you have an increase in pain with someone who has Paget's disease, you have to worry about secondary malignant degeneration. Finally, someone laughed. All right. I think it's in the British Open a couple years ago. All right. Last section on bone, and then we'll go through some questions, and we'll take a few-minute break. Osteonecrosis, death. This is a controversial topic again. Death of bony tissue as a result of a vascular insult. We're not quite sure why it happens. There's been a lot of speculation. It can be idiopathic. It's seen in Legg-Calvé-Perthes disease. It may occur because of coagulation abnormalities, although they're not sure anymore. A few years ago that was an answer, but now they're not quite as clear, so they're not going to ask you why do people get in Legg-Calvé-Perthes, because we haven't figured it out. Femoral head is the most common location. Again, MRI is diagnostic. Risk factors for osteonecrosis, steroid use, heavy alcohol use. What's Caisson's disease? Divers, right? Excessive radiation therapy, Gaucher's, and hemochromatosis. Etiology, there's several theories. Enlargement of marrow fat cells leading to ischemia. There's a vascular insult. Idiopathic osteonecrosis of the hip is called Chandler's disease. Okay? The reason I'm telling you this is because I missed this on my boards, because I didn't know what Chandler's disease was. So it's not that common. That term is there. The eponym doesn't come up that frequently. But there's no identifiable cause. The majority of cases of osteonecrosis is idiopathic. So what is the pathology? Necrotic bone, fibrous tissue, and subchondral collapse. Histology, you get necrotic marrow. The woven bone is laid down on dead trabecular bone, and you have resorption of dead trabeculi and remodeling. So that's creeping substitution. Remember we talked about cancellous bone grafting, healing bone through creeping substitution. Same concept here. During creeping substitution, the bone is the weakest, and you get collapse and fragmentation, and that's the crescent sign that you see in the hip. It's bilateral in the hip, 50% of cases of idiopathic osteonecrosis, 80% in steroid-induced osteonecrosis. So obviously, you should image both hips if you have evidence of AVN of one side. MRI is diagnostic. Osteochondrosis is similar to osteonecrosis, but it's similar pathology as osteonecrosis in adults, but it occurs in children. It occurs in children. It occurs at the traction apophysis in children, and we're not sure, but it may be trauma or a microvascular insult or repetitive insult. Look at this laundry list. You know most of these already, but be familiar with them. They love eponyms on the boards. So they're going to ask you, you know Osgood-Slaughters, you know Sievers and Freibergs and Panners and Kienbachs. Thiemens you may not as be familiar with. Blounce everyone's familiar with, but just be familiar with these osteochondroses, okay? I feel like this right now. All right. Are the Hopkins guys here? Someone raise their hand. Anyone from Hopkins? No. How about Tulane? Scott Montgomery says hello. He wants me to pick on all the Tulane residents. No one? Everyone blew off my lecture? All right, I guess the UVA guys get asked every question then. All right, this is, again, these are the most commonly asked concepts that have in the last 5 years. At what time after fracture is vascular response at the fracture site maximized? So yell out the answer, please. Good. Don't look at everyone look up. Close your books, all right? The common pathologic process that occurs in patients with rickets, regardless of the cause, is a failure to which one? Case. Mineralize the matrix in the zone of provisional calcification. Remember, when in doubt, hypertrophic zone. What is the primary effect of vitamin D? I'm going to just go down each row now and start asking if some people. Doug? Strongly stimulates intestinal absorption of calcium and phosphate. Which of the following is considered a key characteristic of osteoblasts? JT or something? Tulane? JT here? Is there a JT? No. I'm just going to start asking random names. Is there Eric in the crowd? Someone say. Which of the following is considered a key characteristic of osteoblasts? We're responsive to parathyroid hormone, right? Secondary messenger sent to osteoclast. The process of host repair following osteonecrosis is referred to as case? Good. During the repair process of an unstable fracture, the expression of major collagen types during fracture callus formation can best be characterized by what? What type of collagen do you get first? And then when you have bone, you get type 1. Good. What organ secretes calcitonin? Which of the following groups is most at risk for osteoporosis? Good. That's easy. What metabolic bone disease is associated with abnormal osteoclastic function? This is easy. You guys are going to ace this part of the test. All right. 65-year-old man who has had a dull ache in the tibia for several years now has pain so acute that he must use crutches. Levels of serum calcium and phosphorus are normal, but alkaline phosphatase level is elevated. The diagnosis most likely is. Right. So, alkaline phosphatase, measure of increased bone formation, Paget's disease, that should make sense. You worry about malignant transformation. Which of the following is not a manifestation of hyperparathyroidism? Hyperparathyroidism, increased calcium, right? Hypercalcemia. Which one of these is not seen in hypercalcemia? Right? That's hypocalcemia, right? Okay. 8-year-old is dwarf. I guess that's not PC anymore. Short stature and has bow legs. The calcium is low. BUN phosphate and alkaline phosphatase are elevated. Most likely diagnosis is. Say something. Yell it. I mean, it's a giveaway, right? BUN is abnormal. Parathyroid hormone exerts an effect on the intestines by what? It does act on the intestines, but this is the main effect. It stimulates 125 vitamin T, which has a direct effect on the intestines. Remember, the active form of vitamin D. The main physiologic effect of calcitonin is inhibition of bone resorption. A 3-year-old boy with frequent fractures and progressive deformity of long bones with a normal serum calcium and phosphorus and low serum alkaline phosphatase has what? What is it? Right. Again, low serum alkaline phosphatase. It's a giveaway. Vitamin D is converted to 25 vitamin D in which organ? Which one? Good. 25 is converted to 125 in which organ? Kidney. Bisphosphonates are a family of compounds used in the treatment of a variety of metabolic bone disorders. Which of the following osteoclastic function is most directly affected by these compounds? Development of ruffled border, right? Which component of frozen allograft bone has the least amount of immunogenicity? A fully differentiated osteoclast has receptors for which of the following proteins? Calcitonin, right? It's a direct effect from calcitonin. Which of the following substances have been implicated in the pathogenesis of osteoarthritis? IL-1. In patients with osteoporosis, the incidence of fracture is directly related to what? Degree of bone mass loss, right? During fracture healing, which of the following cartilage types is expressed by hypertrophic chondrocytes as the extracellular matrix undergoes calcification? Which one? Good. Osteoclasts are signaled directly via receptors to stop resorbing bone by which of the following substances? Again, right? All of the following substances are osteoconductive except BMP is osteoinductive. All right. 5 minutes, okay? We still have a lot of stuff to go over. Yeah. Oh.
I like hanging out with your brother.
Oh, yeah. How you doing?
I'm your brother Corey. Nice to meet you. The osteocyte, which is a mature osteoblast, really all of a sudden develops a calcitonin receptor when it didn't have it before.
Exactly. Exactly. It's counterintuitive.
Okay.
It does, but it does have a
receptor.
receptor. Yeah, it does.
With
Just remember one thing: osteocyte is maintains bone, so it's going to have an influence on both. You know, it
it's
is
99% of the cell.
Right.
And that just, maybe I made a mistake by reading KU8 because they probably wrote the questions before all this shit came out. But Brassica seems like he's making 24, 25 vitamin D.
Right.
He makes this big thing about how he's active and it supports the growth plate and all this shit. Can I just download that?
Don't
Just throw that away.
Throw that away right now. Let me tell you. Okay, you came out.
After the question.
Yeah, exactly. These questions were written 5 years ago that you're going to be taking this year. So, you have to see what's been accepted literature for a fair amount of time. The problem with it, 24, 25 does have some effect on at certain areas of the bone, but when you look at adult calcium, metabolism, the active form in 125, that has the major effect on metabolism.
And then the calcium in the kidneys, I know that the majority is resorbed at the proximal tubules, but they made it seem like the distal tubules where you regulate. They say like 90% is where it's resorbed, but the distal tubules where you can have your effect with all these medicines. Can I just down?
Well,
I wish I had it right
it's
over
true.
you.
It's true. It does. We're trying to. You can augment or decrease calcium absorption more distally in the kidney, but again, the major effect of these hormones are in the proximal tubules.
I appreciate it. Thank you.
All right.
Yeah, with renal osteodystrophy, you have increased phosphorus, you get increased parathyroid hormone, but yet decreased active form vitamin D.
It's because you have a direct inhibition of because you're right. See, the hardest part when I'm putting these lectures together, it's so hard to make it fit, completely.
No, you can really help me. I hang on to about 3 things and I can figure out everything else.
That's the whole point of it. Is I can't. There's no way you can make everything work. But because what happens is in certain states you get more of an effect at the by phosphorus over calcium. Yeah, exactly. It's more stronger than the other. But we can't. Once you start, you'll blow your mind once you start thinking about it. Just breaking it down keeps it as simple as possible. Because the reality is, you guys know the importance of PTH, vitamin D, and calcitonin. But how much does it affect our practice? There's a broken bone, we fix it. We make sure we don't ignore osteoporosis.
Just stick to those little couple rules.
You'll be fine in all those questions. All right. I mean, I did actually a meta-analysis of all the questions that have been asked in the last 10 years, and I looked at personal meta-analysis of what the most frequently asked questions were, and I looked at about 10 years of OITEs and so forth, and having taken the boards, I was one of those guys who wrote down as many questions as I could before I left the board, which I guess is kind of illegal. But the reality is that the answers, the lab answers, they put all these labs in front of you, they get really confusing. Most people, because they want you to just skip the question, but if you look at it for just 30 seconds, you're like, wait a minute, alkaline phosphatase is elevated. There's only one real sort. I mean, they're so clear, and that was just by experience when I was looking at all these labs. They don't. There's tertiary type questions, where you have to understand something and then apply it again and then apply it again. That's none of these questions. They're all fairly straightforward. It's all memorization, basically. It's variable. vitamin D does affect the kidneys, but its biggest effect is in the intestines.
And then one of those questions said like, what is like hypocalcemic state? It's not right, so it's not like increasing size. So the last answer menstrual testicles. Doesn't that have that? Doesn't that also have hypocalcemic? Is that like when you justify like your hypothalamus?
Well,
Is that
in
menstrual?
hypercalcemia, you get what the last answer was
See,
like.
I did that question,
Yeah.
right? And that question is wrong, like, because the hypocalcemia state is when you get like calcification in your hypothalamus.
You can, yes, but a lot of times when you have ectopic calcification, that's hypercalcemia. That's what's seen in mesothelioma in certain conditions where you have excessive amounts of calcium. You get you do get ectopic calcification because you can get it
In hypo,
occasionally, but the best answer on that question was the muscular.
because the answer to that question didn't make sense.
Yeah, I know. But they didn't throw it out, unfortunately.
Right.
This one, had you definitely the answer that one?
It can. Better answer that. It can. What they're really asking is, you get osteoclastic function, osteoblastic function. You haven't. There's a real way to look at it. Osteoplastic facility, but in osteopathic, it's the interaction between bone formation and bone formation. You have increased bone formation and other forms of development, little baby, squat. One of the things about the board that I mentioned is that the questions are a lot more clear-cut than the OIT. The OIT, there's always 2 or 3 good answers, or maybe there's 2 answers. On the board, there's one good answer. Unfortunately, I can't give you board answers. This is the hardest one, and that's why it's
Your level of prostate normal, even with all those prostate
no, you should level it out.
why would that?
It should increase the beginning, but if you're not having normal absorption of the prostate in your tubule, so you do have a decreased level of prostate, which the normal sense, you got to think about it, vitamin D should go up. You have to have vitamin D. But and it's considered normal, but it should be sky high. For some reason, in pathologic states, you don't get upregulation of vitamin D. You have to know that. And that's why I said, if you get into Rick's question that doesn't make sense, yes, familiar.
Video of your chart wasn't up there, so
Oh, it wasn't? Which one?
for the
Bone grafts? Okay. All right.
I mean, show it like
Okay.
something like
All right. Okay.
Okay.
Hey. Hey, how you doing? I'm on at 10, right? So I have an hour and a half left. So. It's going good. Good.
Glitches of this stuff?
No, not at all. Not at all. Same as last year. Same as every year. So it's pretty straightforward. I just loaded my talk directly on here.
I
You're just getting it down.
Yeah, I got it last time, didn't I?
Yeah.
My face went sour. I was supposed to get an early. I didn't update my, I didn't put my image screen stuff in my screen from last year on, but I'll have to do it early. I'll be updating it too.
I should be done. It's 8:35. Yeah, there's a break after mine. I think there's a 20-minute break, so that should get it. I put my last. I was looking on questions too, so that's just crazy. This talk, you figure you have it all done, and you've done it for many years. So, and keep having to update it. 375. 350. No, just 2 years ago it was bigger. No, it was 3. I think it's 325.
325?
Yeah. Academy.
Academy review?
The Academy review course.
That's the 2-day one?
No, it's now 4 days this year. Frasica's in charge of the Academy review now, so Frank Frasica at Hopkins.
Pretty good?
Yeah, I was there giving some talks, and it was not anywhere near as good as this one, but there were 250 people there, so that's probably. All right, everyone, let's get started. This is going to be much easier than, can everyone hear me? Okay. This section, the next two sections are going to be much easier. We're going to go through this because we have about an hour and a half to get through this. One point I wanted to make, a lot of these OITE questions, I know you've experienced it, that you're taking them and there always seems to be two good answers or sometimes three good answers. And there's supposed to be one best answer, but that's not always so clear. From the board standpoint, there's always one very clear answer. So the OIT is always a little bit harder than the boards, just to, if that one puts anyone's mind at ease. Doesn't mean you don't have to study for the boards, but the questions are, there's not as many controversial questions or questions that there may be two right answers. All right, let's start with neuromuscular and connective tissues. This is much easier, and again, this should be a review for everyone. We'll start with skeletal muscle, non-contractile elements, contractile elements, action, type of muscle contraction, type of muscle fibers, energetics, and then we'll talk a little bit about athletics and training. This is a review of basic, high school and college biology. So there are a few questions and pearls that you'll get out of this section. Should be familiar with a lot of this. So non-contractile elements, muscle body, you got the epimysium, which surrounds muscle bundles, the paramysium surrounds muscle fascicles, and the endomysium surrounds individual muscle fibers. The myotendon junction is the weakest link, and it's the site of injury, particularly with eccentric contraction. They like eccentric contraction questions on the boards in OITE. Sarcoplasmic reticulum stores calcium that's necessary for muscle contraction. Again, look just epimysium, paramysium, and endomysium. The contractile elements of skeletal muscle are derived from myoblasts. The fascicles make fibers, which make myofibrils. Myofibrils are a collection of sarcomeres. You remember this wonderful diagram here, the sarcomere. Z lines, I, A, H, M zone, so forth. Again, a review, but it's helpful to know this. So their sarcomere is composed of thick and thin filaments in an intrinsic arrangement that allows fibers to slide past each other in response to calcium. The thick filaments are myosin. The thin filaments are actin. There's the H band, which is the myosin thick filament zone. The I band is the actin thin filament zone. The Z line are the attachment of the thin filaments. The A band contains both actin and myosin. The M line is the interconnecting site of the thick filaments. The sarcomere is defined as Z line to Z line. There has been a question in the past of which zone or line or band contains both actin and myosin filaments, and that's the A band. And remember this you guys should remember this from high school biology, but just look at it quickly. Action. What happens when a muscle contracts? You get origination of a signal in the cell body of a nerve. The stimulus is carried to the neuromuscular junction via electrical impulses that are propagated down an axon. The impulse reaches the motor end plate where you have release of acetylcholine, which diffuses across the synaptic cleft and stimulates a receptor on the other side, and you get your muscle contraction. Acetylcholine diffuses to specific receptors on the muscle membrane. The receptor activation triggers depolarization of the sarcoplasmic reticulum, which causes release of calcium. And calcium affects troponin and tropomyosin, which will, if you remember those terms, and that causes the sliding of the filaments. Just a graph of the neuromuscular junction. What pathologic state do you get when you have an antagonist to acetylcholine in the neuromuscular junction? Myasthenia, right. So what happens? How does calcium? Sarcoplasmic reticulum releases calcium. Troponin and tropomyosin are the regulatory proteins on skeletal muscle. Tropomyosin prevents cross bridges from forming actin, from binding with actin. So the actin and myosin are not allowed to bind because of the configuration of the tropomyosin. Troponin is on the tropomyosin. Troponin is calcium sensitive. The calcium binds to troponin. It induces a change on the tropomyosin, which allows the actin and myosin fibers to interact, and then you get sliding of the fibers. So again, blast from the past, high school biology. So what happens again after release from the sarcoplasmic reticulum? Calcium binds to troponin, which is, again, on near the thin filaments. The calcium activation of troponin causes a change in the position of the tropomyosin, which is on the thin filaments as well, exposing these actin filaments. The exposed actin filaments form cross bridges with myosin, and ATB breakdown results in sliding of thick and thin filaments past one another. The sliding of these filaments causes muscle contraction. In review. So you can see, again, calcium is important, affects troponin, which changes the configuration of tropomyosin, which exposes the cross-links for actin and myosin. And then once the actin and myosin are cross-linked, ATP is the fuel that causes the sliding and the contraction of the sarcomere. And the multiple sarcomeres in line cause your multiple contractions. So what type of muscle contractions are there? They love these questions. They're very easy. They're all definitions, okay? But they love these questions. Isotonic, isometric, and isokinetic. Isotonic, isotone, same tone. So the muscle tension is constant through a range of motion. You keep your tone the same throughout your range of motion. The muscle length is what changes. It's a measure of dynamic strength. Isotonic is like a biceps curl. You have phases. You can get a concentric contraction. In the curl portion, you can have an eccentric contraction, which is a negative when you're doing a biceps negative, but you have potential for muscle injury, particularly at the musculotendinous junction. Isometric means you maintain the same length. Muscle length is constant during the exercise. The tension is what changes. It's a measure of static strength. It's essentially an example of pushing against an immovable object, pushing up against a wall. Muscle velocity, isokinetic, that's where isokinetic, muscle velocity is constant. The tension is generated through a range of motion. It's a measure of dynamic strength. It's best for maximizing your strength. Isokinetic exercises require special equipment, such as Cybex machines. Type of muscle fibers, again, we're talking about the basic science of muscle. So slow twitch is type 1. Fast twitch are divided into type 2A and B. Type 1 fibers are oxidative, or the red fibers. They're aerobic, so they have more mitochondria. So just remember a mnemonic, slow red ox, so they're oxidative. And red fibers, they're long-distance runners, all these Kenyans, marathon runners, they have very high levels of slow twitch fibers. They have a high amount of aerobic metabolism. Fast twitch fibers are seen in sprinters. They're white fibers as opposed to the red. They're glycolytic, not aerobic. They contract very quickly. They can generate a large amount of strength. They're anaerobic, so they can give you a very strong contraction, but they don't last very long because they're anaerobic. They're less efficient. They're, again, suited for more sprinting activities, and they fatigue rapidly compared to the aerobic slow twitch fibers. There's 3 energy systems that generate muscle activity. Which system is used depends on the duration and activity of muscle action required. All right. Again, by basic biology, don't freak out because I'm going to put a picture of the Krebs cycle on the screen. So you have three types of mechanisms that generate muscle activity. You have the adenosine triphosphate creatinine phosphate system, or the phosphagen system. You have the lactic or anaerobic system, or the glycolytic pathway, and then you have the aerobic system, which is the oxidative pathway. The phosphagen system meets the metabolic requirements for intense muscle activity that lasts for 20 seconds, so a 100-meter dash for some of us. For me, I probably go into a lot of others. It uses stored carbohydrates from within the muscle fiber itself, does not use oxygen, and does not produce lactate. Its energy would derive from high energy phosphate bonds. So ATP breaks down to ADP, and you get energy. It lasts for 20 seconds. Again, it's for the immediate carbohydrate stores within the muscles. It's for early exercises. After that, the phosphagen system, you convert to the glycolytic system. So it meets the metabolic requirements for episodes of intense muscle activities that last between 20 and 120 seconds. It's the anaerobic metabolism, so you get hydrolysis of glucose muscles that produce lactic acid and energy. This is why you get sore, because of your lactic acidosis buildup. Enough energy to convert 2 molecules, doesn't seem like a lot, 2 molecules of ADP to ATP from 1 molecule of glucose. So this is the glycolytic pathway. The oxidative pathway is when oxygen is available, aerobic metabolism is responsible for the replenishment of ATP. You have oxidative phosphorylation. You have the Krebs cycle. Glucose and fatty acids are used to make ATP. It meets the metabolic requirements for long-duration, low-intensity muscle exercises, essentially endurance exercises. 34 ATP per muscle of glucose. That's been asked. Okay? You should remember that from biology as well. Again, Krebs cycle, don't spend time, just know 34 ATP. Here's a chart that's important. The ATP, the phosphagen system, is what's first in the first few seconds. Then the glycolytic system kicks in, and then for more longer duration exercises, you have the aerobic metabolism. In training, the distribution in fast twitch and slow twitch fibers are genetically determined. You can't make yourself get more slow twitch fibers. Selective training can improve the function and efficiency of the existing fibers that you have. That's why not all of us can be long-distance marathon runners. Endurance athletes have higher levels of slow twitch fibers, whereas sprinters have high levels of fast twitch fibers. Endurance, when you're training to improve endurance, you decrease tension and increase repetition, and that causes an increase in the number of mitochondria, capillary density, and oxidative capacity. You make the slow twitch fibers more efficient. For strength, you want to increase tension and decrease repetitions. You can increase the number of myofibril or fibers. You get hypertrophy of fast twitch fibers. Remember, these are short duration, high intensity muscle contractions. Contractile strength is proportional to the cross-sectional area of your muscle fibers. Isokinetic exercises are the most efficient in giving you strength and produce more strength. Plyometric exercises are muscle stretching cycles followed by rapid shortening cycles. Stretching leads to a storage of elastic energy. Plyometrics, I just remember P, this is what gives you power. I think a lot of these exercises, people carrying weights and trying to jump onto a height, carrying weights, that gives, again, a rapid muscle stretching and shortening cycle, and you get an increase of storage of elastic energy, which gives you your initial burst or your initial power. There are a few steroid questions they ask. Anabolic steroids are androgenic. If you look at all of the benefits, you can see there's quite a bit of negative or drawbacks as well. They may give you short-term increased muscle strength, aggressiveness, but it causes atrophy, testicular atrophy, make you sterile, can cause gynecomastia in men, hypertension, liver tumors, and increased LDL cholesterol levels. The female athlete, amenorrhea occurs because of a decrease in the percentage of body fat. You have hormonal changes which affect your hypothalamic pituitary axis. The triad is amenorrhea, osteoporosis, and anorexia. Muscle injuries, muscle strains occur at the myotendinous junction. Muscle soreness is an eccentric muscle contraction that you get changes in the I band of the sarcomere. Remember the I band? Muscle tears occur at the myotendinous junction as well. They heal with dense fibrosis. If you have a mid-substance muscle belly tear, only half your muscle strength recovers after healing. Again, EM of a myotendinous junction. So let's look at the nervous system, the central nervous system, and the peripheral nervous system. This again is a review. CNS is brain and spinal cord, and peripheral nervous system. CNS, just some factoids. Stroke patients can improve up to 6 months after vascular events. Traumatic brain injury improves up to 18 months. Folic acid supplementation reduces incidence of children being born with myelomeningocele. I'm not sure concussion is covered elsewhere, but just they occasionally like to ask you grades of concussion, so we'll cover it here since we're talking about the CNS. It's a jarring injury to the brain, grade 1, 2, and 3. Grade 1 is a mild concussion. No loss of consciousness, no retrograde amnesia. You can return to play when asymptomatic. Long-term suspension of play if you've had 3 grade 1 concussions. Grade 2 is moderate. You have a loss of consciousness for less than 5 minutes. You have retrograde amnesia. Confusion and disorientation resolves rapidly. The first episode, you can return to play after a week. If you have repeat episodes of long-term suspension of play. Grade 3 is the most severe. Some of our talented quarterbacks, Steve Young, in recent history, you get prolonged unconsciousness, permanent retrograde amnesia, confusion and disorientation persist, long-term suspension of play. If you've had more than 1 grade 3 concussion, you may consider not playing anymore. So peripheral nervous system. The nerves are composed of bundles of axons enclosed in connective tissue sheath. Nerve fibers, you get axon plus the surrounding Schwann cell. Again, this is basic biology. Myelinated fibers conduct faster than unmyelinated fibers. Here's an EM of a myelinated fiber up here, and these are unmyelinated fibers down here. What happens along the peripheral nerve? You have a cell body, which is the metabolic center. The axon is the primary conducting vehicle, conveys electrical impulses via action potentials. Dendrites communicate with the surrounding nerve cells, and the presynaptic terminal is where you get transmission of information from one neuron through another through diffusion across the cleft. So again, here's a neuron and the presynaptic terminal and the postsynaptic membrane. The glial cells associated with nerves, Schwann cells, myelinate peripheral nerve axons. The loss of myelin sheath disrupts conduction velocity. That's what you see in neuropraxia, and we'll talk about that briefly. Myelin is composed mainly of lipid or adipose and 30% protein. Oligodendrocytes are only in the CNS and form myelin, whereas the astrocytes are also in the CNS and form myelin. Oligodendrocytes and astrocytes are not in the peripheral nervous system. Those are Schwann cells. So Schwann cells are in the peripheral nervous system. Oligodendrocytes and astrocytes are the glial cells in the central nervous system. Again, just like we talked about muscle action, let's talk about nerves. So you have a resting potential, which is an unequal distribution of ions on either side of the neuronal cell membrane. The resting potential is negatively charged. The action potential transmits signals via an electrical impulse. You get depolarization, and the action potential results in an increase in cell membrane permeability to sodium. This is a voltage-gated channel. There's voltage-gated, mechanical-gated, and chemical transmitter-gated channels. But you essentially get redistribution of sodium and potassium across the membrane, and that results in a depolarization and an action potential. So everyone should be familiar with the depolarization. You get overshoot, repolarization, and then the resting membrane potential, which is negatively charged. This is, again, review. So you get a stimulus, increased cell permeability to sodium, depolarization, action potential, the action potential travels down the axon. You get a transmitter release at the presynaptic junction, diffusion of the transmitter to the postsynaptic membrane, and that either causes a muscle contraction or it stimulates the next neuron that's downstream. Sensory system, you have a stimulus from the environment that's transmitted via sensory receptors or afferents to the CNS. You can have photo, mechanoreceptors, thermoreceptors, chemoreceptors, and pain receptors. Somatosensory input is transmitted to the spinal cord versus the dorsal root ganglion. Everyone should be familiar with that. Motor system in the CNS is comprised of spinal cord, brainstem, cortex, basal ganglia, cerebellum. I'm moving fast here because this is a review. Spinal cord, white matter is the peripheral ascending and descending tracts of myelinated and unmyelinated axons. The gray matter is the central portion where you have the neuronal cell bodies, the glial cell, dendrites, and axons. Again, here's a schematic of the gray matter and the white matter where you have your ascending and descending motor tracts. There's three types of neurons in the gray matter. You have a motor neuron, which exits the CNS via the ventral root. You have an interneuron, which remains in the spinal cord, and you have a tract cell, which goes up to the brain. What is a spinal cord reflex? It's a stereotyped response to a specific sensory stimulus. You have a pathway, a sensory organ, an interneuron, and then a motor neuron. A monosynaptic reflex is one synapse involved. A polysynaptic reflex involves multiple interneurons and are most human reflexes. What is a motor unit? It's composed of a motor neuron and all the muscle fibers it innervates. There's 4 types of motor units. Don't get too lost in this, but type S is slow, fatigue resistance. FR is fatigue resistant, fast, fast intermediate, and fast fatigue. So upper motor neuron is located in the descending pathways of the cortex, brainstem, and spinal cord. Lower motor neuron is located in the ventral gray matter of the spinal cord, as we mentioned. Everyone is familiar with upper motor neuron lesions, lower motor neuron lesions. We'll leave that to the spine section there, but you guys should be familiar with this. All right. Peripheral nerves, composed of nerve fibers, blood vessels, and connective tissues. The nerve fibers are surrounded by endoneurium. The fibers are grouped into bundles called fascicles, and fascicles are covered by perineurium. The peripheral nerves are composed of fascicles which are surrounded by epineurium. Epineurium is critical for nerve repair. Again, it's another schematic showing the organization. You can have monofascicular nerves, you can have oligofascicular nerves, and you can have polyfascicular nerves. That has implications in nerve repair, which I'll let Dr. Howard talk specifically about in the hand section. But then there's three types of nerve fibers. Type A are the largest heavy myelinated nerves. Type B is the intermediate myelinated nerves seen in the autonomic nervous system. Type C are no myelination, and they're the slow speed, and they're the pain nerve fibers. And type C fibers are what they've asked before. What type of nerve fibers are associated with pain, and those are the type C fibers. Peripheral nerves anatomy, again, conduction is facilitated by gaps between Schwann cells, or the nodes of Ranvier. Blood supply is extrinsic. All these nerves have significant extrinsic blood supply, but they also have an incredible vascular plexus that's intrinsic within the epineurium, perineurium, and endoneurium. That's why you can transpose an ulnar nerve, because you can devascularize it essentially extrinsically, but it has an incredible amount of intrinsic blood supply, which allows you to transpose a nerve without getting a nerve palsy. Injury leads to death. The distal axons or Wallerian degeneration. Proximal axonal budding occurs 1 month after the injury, so there's a delay in healing. Remember Sedan's rule that nerve regeneration occurs 1 millimeter a day. Pain is the first modality to return often. Neuropraxia, peripheral nerve injuries. Know these definitions: neuropraxia, axonotmesis, and neurotmesis. Neuropraxia, you have a local ischemia and a selective demyelination, so you have an effect of the conduction of the nerve fibers. Prognosis is very good with time. The next one, axonotmesis, you have axon and myelin sheath is disrupted, but the epineurium is intact, so the conduit is still intact. The prognosis is fair. The last one, you have complete division, and the endoneurium is disrupted, and obviously the prognosis is the poorest for this. Peripheral nerve recovery is influenced by contact guidance, neurotrophism, which are factors enhancing growth, and neurotropism, which are attraction to nerve tissue. There's obviously a lot of basic science research going into augmenting nerve repair with these neurotropic factors to help enhance healing. Everyone's familiar with EMGs and nerve conduction studies that are helpful in determining the extent of the injury and monitoring recovery. In general, young patients do better. There's several methods of peripheral nerve repair. You can have direct muscular neurotization, where you actually plug the nerve into the muscle. That has very poor results. Epineural repair is the most common. You can get group fascicular repair, and at certain levels, they say at the elbow, ulnar nerve at the elbow, median nerve at the wrist. Maybe group fascicular repair is better. Conduit repairs are being done for digital nerves with segmental gaps. Nerve grafting is also done, particularly in brachial plexus lesions. Vascularized nerve transfers can be done also for certain brachial plexus lesions. Epineural repair is often the answer. Okay, there's a lot of debate. Is group fascicular repair better than epineural repair? There's been no real literature that has shown that long-term that you have a better recovery with one repair type over another. Nerve repair is incredibly variable still. We still have not figured out how to get the best outcome from these nerve repairs, despite all these current research trends and suture microsurgical repair techniques. So the main thing to know, again, about nerve repair is what's important is you align the nerve ends as best as possible. So you can line up the fascicles, you can line up the vascular marking on the epineurium, and just lining up the nerves ends as much as possible is what's going to give you the best overall results. So last section on this part, tendons, dense, regularly arranged tissues that attach muscle to bone. Again, a review composed of fibroblasts. Type 1 collagen is 85%. The fascicles are separated by endotenon and surrounded by epitenon. So again, the basic structure of a tendon. You can see the fascicles here, and then you can see the epitenon is a very thick layer here. Epitenon is important in flexor tendon repairs. Obviously, they augment your core suture repair by 30 to 50%. There's 4 types. There's tendon insertion into the bone goes through a transition of tissues, and that's because for force dissipation, the tendon becomes fibrocartilage, then mineralized fibrocartilage, which is the Sharpie's fibers, and then it inserts on bone. The peritoneon-covered tendons, such as the Achilles, are very vascular. They have a very rich capillary system. The sheath tendons are the hand flexors. The mesotendon is the vincula, which carries a vessel that supplies one segment of the tendon, and the remainder of the tendon is avascular and receives its nutrition via diffusion from that one vascularized segment. So that's why flexor tendon repairs in the hand don't do as well as Achilles tendon repairs. Peritoneum-covered tendons have better healing because of their increased vascularity. Here's the peritoneum vascularity. You can see it's quite diffuse, but look at a sheath tendon, such as a flexor tendon. You can see that you get blood flow, or you get vascularity from the vincula, and it's a very limited area, and then you depend on diffusion within the tendon sheath, or imbibition, essentially, within the tendon sheath to provide nutrition to the other areas of the tendon. Tendon healing is initiated by fibroblasts and macrophages. Repair is weakest at around 7 to 10 days, maximum strength at 6 months. Immobilization may increase strength of the tendon, but obviously you get tendon adhesions, particularly in the hand. So the ideal scenario is to move them without stressing the tendon repair, so you need to do certain protective mobilizations to allow passive motion exercises without stressing the repair, preventing adhesions, allowing for excursion. Early motion is important, and immobilization, while it's great for increasing the strength of the tendon repair, it results in increased adhesions and poor functional outcomes. Ligaments, now remember, tendons were 85% type 1 collagens. Ligaments are a little less. They're 70% type 1 collagen. They stabilize joints, similar structure to tendons, but fibers are more variable, and there's a much higher elastin content. Ligaments have uniform microvascularity that occurs through the insertion site. These are much more vascularized, and they possess mechanoreceptors and nerve endings. That's why you have pain when you rupture your ACL. Ligament insertion into the bone, there's two types. There's an indirect insertion. The superficial fibers insert at acute angles into the periosteum. They've asked this in the past on the OITE. I don't think it's that important for the boards, but just know there's two ligament insertions. You have an indirect insertion, which is the most common, where the fibers here insert directly into the periosteum. Here's the bone. Here's the ligament fibers into the bone. So there's a direct insertion, which is less common. And this goes through the transition of tissues, just like the tendon insertions. You have superficial and deep fibers. The deep fibers insert at 90-degree angles to the bone. You have the ligament, fibrocartilage, mineralized fibrocartilage, and then bone. That's for the purpose of force dissipation. So ligament, fibrocartilage, and then into the bone. Ligament healing is improved with normal stress and strain across the joint. That's why we move people early after ligament repairs, if we can. Early ligament healing is seen. Now, the types of collagen. We talked about type 1. We talked about type 2. We talked about type 10. Type 3 collagen is seen in early tendon and ligament healing. Okay, so they've asked that question before. So type 3 is a favorite for early ligament and tendon healing. It's later converted to type 1. Ligament injury, the most common mechanism of failure is rupture of sequential series of collagen fiber bundles. Mid-substance tears occur in adults. Avulsion injuries occur in children. Avulsion of the ligaments occur between the unmineralized and mineralized fibrocartilage layers, and that's the weakest point in the ligament insertion. Intervertebral disc pathology, there's two components. There's the nucleus pulposus, which has high glycosaminoglycan and low collagen content, and that allows for compressibility. Remember, proteoglycans are important for compressibility. The nucleus is composed mainly of type 2 as opposed to the annulus, which is type 1. That has more tensile strength because it has more type 1 collagen. Nerve fibers are present. That's why if you herniate through your annulus, you get pain. The intervertebral disc is 85% water. So here's the structure of the annulus, which is type 1 collagen, well organized, as opposed to the nucleus pulposus, which is more type 2 collagen as well as proteoglycans, and it's less well organized. In the aging disc, they've asked questions, what happens? You have decreased water content. Proteoglycans tend to attract water, so if you have less proteoglycans, less water content, you have increased collagen diameter. Cigarette smoking is a risk factor for degenerative disc disease. Any Star Wars fans out here? Anyone seen the new Star Wars? Guy's got no hands, obviously. All right. Let's do a few questions here. But see, that was a lot easier than the bone section. These are easy questions. You guys are going to ace this portion of the test. So healing after complete mid-substance laceration of skeletal muscle in an adult is characterized by what? How does it heal? Don't look at your books, please. dense connective scar tissue. Osteoporosis in 24-year-old female marathon runners commonly associated with amenorrhea. Which of the following is considered a serious and possible irreversible side effect of anabolic steroid use? Irreversible. So which one of these looks irreversible? Growth retardation, right. Everything else is reversible. What muscle action is defined by muscle activation with simultaneous muscle lengthening? Eccentric. Very good. And that's has your highest potential for injury. Type 1 skeletal muscle fibers are characterized by what? Anyone? Type 1, right? Slow red ox, right? Low strength of contraction, but you have prolonged duration, as opposed to type 2, which are the fast speed seen in sprinters. In muscle anatomy, what characteristics is seen in fast glycolytic type 2B fibers? Case? High anaerobic capacity, very good. To maximize the potential for functional recovery of a cut nerve during surgical repair, it is of utmost importance to what? Properly align the nerve ends during repair, right? A woman sustains a grade 2 partial tear of the hamstring muscle during a sudden stretch while sprinting. The tear usually occurs at what junction or what level? Right, my tendon. Which of the following is considered the primary factor resulting in a decreased ability of the intervertebral disc to maintain a high water concentration? Doug? Very good. All right. What is the major constituent of the intervertebral disc in a 20-year-old patient? Disc is composed mainly of water. Strength training at a constant velocity using submaximal and maximal contraction describes what type of training? Constant velocity, so what is it? Isokinetic. Good. All right, more Redskin trivia. Who's 81? All right. Who's number 3? A little bit harder. Who is it? Mark Mosley. Right. Good. You guys are going to learn something important here. All right. After you take your boards, in the same hotel you take your boards, there's a bar called Big Bar. It's like the longest bar in the U.S. or something like that. The beers are about that big. So for the first half hour, everyone's quiet and miserable because they just felt like they failed. And about half hour later, the whole place is flying high. All right. Now, let's start this section. And I know you guys, it's hard for me to get, you probably won't believe me when I say this because you haven't taken your exam yet. This is by far the easiest section of basic science. And the reason I say that all the questions are definitions. If you know the definitions, you will get the answer right. They don't ask you to figure out the sine or cosine of this and that. They don't ask you that. They want to know a definition of what's anisotropy. You know, that's what they're asking. So these questions are fairly straightforward. This is essentially biomechanics for dummies. They don't expect you to be a PhD in biomechanics here. Very few orthopedists have a strong understanding of biomechanics principles. We have the basic understandings. So the definitions are key here. So let's start by describing those definitions. We have about 40 minutes left. We're going to go over about 30 or so questions after this section as well. So hopefully you'll feel a lot more comfortable that this is the type of questions you're expected to know and the level of difficulty as well. So basic quantities are SI units. The derived quantities are velocity, which is meters per second, which is the rate of change of displacement. Acceleration is meters per second squared, or rate of change of velocity. And the force, the unit is newtons, which is action of one body on another, kilogram meters per, over a second squared. Newton's laws, this is all basic physics. First law, inertia is the sum of the external forces applied to a body, which is 0, and that's static analysis. The second law is acceleration is directly proportional to the force applied to the object, and you need that for dynamic analysis. The third law is the reactions. For every action, there's an equal and opposite reaction, the famous Newton's law, right? Well, you need that law to do free body diagrams. Know what a vector is. Scalar quantities are quantities that have a magnitude but no direction. So they're volume, time, mass, and speed. A vector is a magnitude and direction, force, velocity. Vectors can be added, subtracted, and split into components. You have to understand that to do your free body diagrams. Free body analysis. There may be one question on boards, okay? And it's going to be very straightforward. But just you should just spend very little time looking at this, because don't try to spend too much time. There's more important things to study and know. But when you do free body analysis, there's always a resultant force, which is a single force equivalent to the system of forces acting on the body. So essentially, the resultant force here is going to be the weight of this person and the weight of this person here. And then there's an equilibrant force, which is going to be of equal magnitude and opposite to the resultant force. And that's what keeps this seesaw in equilibrium. And this is Newton's third law. For every force, there's an opposite force in a state of equilibrium. What's a moment? A moment is the rotational effect of a force on a body at a point. A moment is defined as force times distance. So the distance is the moment arm. So the force around this point here is going to be the force applied to this wrench times L or D, which is the moment arm. Know the definition of mass moment of inertia. It's the resistance to rotation. There have been questions where they ask you, what is the mass moment of inertia? Okay? So a lot of these is, again, definitions. Free body diagrams, all the forces acting on a body. The weight of the object acts through the center of gravity. Just briefly look at these and just have a basic understanding. In this scenario here, the weight of this object in the hand, what's the moment of this object? It's the weight times its distance from the center of gravity, right? So that's what's going to try to be forcing you to topple over. You also have to take into account the weight of the arm, since the weight of the arm has a moment too from the center of gravity. So what they'll ask you is, what is the force of the paraspinal muscles that keep you from toppling over? It's going to be equal to but opposite this. So it's going to be a force time a distance from the center of gravity. So the force of your muscles, lumbar muscles, times the distance to the center of gravity is going to equal this weight times the distance, which is the moment arm, plus the weight of the arm times the distance. This is an equilibrant scenario. That's why you don't topple over carrying weights in front of you. For every force is an opposite force, an equal and opposite force. These questions are fairly straightforward. You have to know the concept of equilibrium. You identify a system, select a coordinate system, free body diagram, apply Newton's laws, and solve for the unknowns. They're going to make it easy if they ask you a question. You know, they always show this hip one. There's one in the new Miller's text about biceps, flexion and a moment arm from carrying a weight. Just look at that briefly and it'll make sense. In this scenario, they're asking you for the abductor force, and what the center, essentially the abductor force is going to be the force times the moment arm from the center of rotation around the hip is going to equal the moment arm plus the weight of the body, and that should be equal to prevent rotation one way or another. So essentially, they've solved for the abductor force. In this scenario. They'll keep them simple if they do ask you this question, okay? Now, there's always a resultant or equilibrant force at the joint reactive force. You have force here, you have a force here that is, they're both resultant forces, and then you have an equilibrant force here, or the joint reactive force. How do you determine that? They're never going to ask you that, because the reality is, to figure that out, you have to know how to do sines and cosines, and if you know how to do that, you shouldn't be an orthopedic surgeon. So, except case. All right, case, fine. PhD or so, that's fine. So, other definitions. Work is a force acting on a body to cause displacement. So work is measured in joules or Newton meters. Energy is the ability to perform work. There's a law of conservation. Energy is neither created nor destroyed. It's transferred from one condition to another. That has implications in high-energy fractures. That's why you have such comminution of fractures in those scenarios, because energy is dissipated to the fracture. It's not created or destroyed. It's just transferred into to one condition to another. The potential energy is stored energy. It's the ability of the body to do work as a result of position. Kinetic energy is the energy of the object due to motion, 1/2 mv squared. Friction is resistance between two bodies when one slides over the other. Obviously, the applied force has to be greater than friction to get motion. Definitions are the key. Again, I can't emphasize that enough for the biomechanics section of the portion of the test. All right, more Star Wars stuff. A lot of this stuff makes you feel stupid, I know, but biomaterials. This is the more critical portion. This has to do with the implants. Again, definitions. What's stress? It's the intensity of internal force. Stress is force over area. It's the internal resistance of a body to a load. Stress is measured in pascals. So it's the internal resistance of a body to a load, force over area. Strain is the measure of deformation of a body as a result of the load. Strain is a change in length over the original length. Strain is a proportion, has no units. That was on my board exam. Which one of these does not have units? They listed strain, force, work, so forth. Stress. So strain is the one that is, you're taking the change in length over the original length. Stress-strain curve. Know this. There's always one or two questions on this, and you should be familiar with this. Stress-strain curve. E is Young's modulus of elasticity, which we'll talk about, which occurs in the elastic or plastic strain deformation zone. You have a yield point, you have the ultimate strength, and then you have a breaking point. So let's go over these definitions again. The yield point, or the proportional limit, is the transition point from the elastic to the plastic range. And essentially, in this portion, the linear portion of the stress-strain curve, if you have a load or stress that's applied anywhere in this zone, it'll return to its normal shape if you relieve that stress. However, if you reach the yield point, you'll start getting plastic deformation. Ultimate strength is the maximum strength obtained by the material. The breaking point is where the material fractures. Plastic deformation is the change in length after removing the load in the plastic range. So you have a permanent deformation. Strain energy is the capacity of material to absorb energy under the stress-strain curve. They rarely ask that, but again, for completeness' sake, know these definitions, know how to interpret this curve. Hooke's law is stress is proportional to strain up to the proportional limit. So that's up to the yield point. So when stress is proportional to strain right here, the linear portion of the curve, you can calculate Young's modulus of elasticity. This is a measure of the stiffness of the material. E is stress over strain in the elastic zone only. Now, materials and structures. Material properties are related to a substance or element. So they're defined by mechanical properties. Force, stress, strain, elasticity, plasticity. Viscosity was its resistance to flow, and strength. So what are the material properties of the things we use? Brittle materials is PMMA. It exhibits a linear stress-strain curve up to a point of failure. There is no real plastic deformation for PMMA. It undergoes only fully recoverable elastic deformation, and then it reaches a point where it fails. What is a ductile material? There's a large amount of plastic deformation prior to failure. Ductility is post-yield deformation. This is the opposite of PMMA, where you get, and this is seen in metals, where you can load something and you'll get an incredible amount of deformation that's permanent, so plastic deformation, before you get failure. What's viscoelasticity? This is seen in bone and ligaments. They exhibit stress and strain behavior that is time-dependent, and material deformation depends on load and rate of application. So how fast you load it and how much you load it affects its material properties, and that's viscoelasticity. What are isotropic materials? Again, definitions. Possess the same mechanical properties in all directions. Anisotropic materials are most musculoskeletal tissues. They have mechanical properties that vary with the orientation of loading. So how you load the bone is going to determine its material properties. Now, structural properties are related not just to the material, but the shape of the object and its loading characteristics. So this is a load deformation curve, which is similar to a stress strain curve. They're often used interchangeably. But slope of the load deformation curve gives you rigidity, and slope of the stress strain curve gives you stiffness, which is a material property. Slope of the load deformation is rigidity, which gives you a structural property. They're often used interchangeably in these in the type of questions. A true biomechanics person would cringe if at the thought of that, but from what the type of questions they ask you, they're sort of used interchangeably. So these are the key equations they're going to ask you. The bending rigidity of a rectangular structure is to the third power. So if you increase the thickness of a plate by 2, you're going to increase its bending rigidity by 8. Okay? Bending rigidity of a cylinder is to the 4th power. So there's several questions we'll go over, but remember, to the 3rd for plates, to the 4th for a cylinder. Area moment of inertia is resistance to bending. Polar moment of inertia is resistance to torsion. And we've already talked about mass moment of inertia, which is resistance to rotation. Again, know the definitions. Orthopedic materials. Again, more definitions. What's fatigue failure? It occurs with repetitive loading cycles below the ultimate tensile strength. If stress is less than the endurance limit, that means the endurance limit is where it'll fail, or fatigue. So the material can be loaded an infinite number of times without failure. And once you get above the endurance limit, you get fatigue failure. And this has implications in hardware failure around non-unions. What's creep? This is another characteristic of metals. It's also called cold flow. It's progressive deformation of metals in response to a constant applied force over an extensive period of time. It can produce permanent deformity and affect mechanical function and has implications in total joint orthoplasty. Corrosion. Again, they like these questions, but it's definitions. It's a chemical dissolving of metals in this high saline environment of the body. Galvanic corrosion occurs between dissimilar metals. That's why you don't want to mix stainless steel screws with titanium plates. Crevice corrosion occurs quite frequently in stainless steel, but it occurs in fatigue cracks with low oxygen tension. Stress corrosion occurs in high areas of stress gradients, and fretting is from small movements abrading an outside layer and also has implications in total joint orthoplasty. So stainless steel is the most likely metal to experience crevice corrosion. Stainless steel and cobalt chrome have the highest risk of galvanic corrosion. There's two dissimilar metals. Corrosion can be reduced by using similar metals for screws and plates, and that's called passivation, where you get a self-passivate coating of a metal with a thin layer that separates the metal from the solution. One type of metal does that on its own. It's called self-passivation, and that's titanium. So the most common orthopedic implants use a low-carbon stainless steel, which is an alloy of iron, chromium, and nickel. There's a cobalt chrome molybdenum alloy, and there's a titanium alloy are the most common orthopedic implants. There's problems associated with implants that all are familiar with. If you have a very rigid implant, you get a lot of stress shielding. So if you have a high Young's modulus of elasticity, you get a lot of stress shielding. There's some questions of ion release from some of these implants. Obviously in total joint arthroplasty as well. Wear debris may incite a histiocytic response. There's been no proof that these cause malignancy. At this point, cobalt chrome generates less metal debris in total hips than titanium. That's why most of the implants, the cobalt chrome femoral heads, are used. Titanium has poor resistance to wear. Passivation improves fatigue properties. It's extremely biocompatible because its modulus of elasticity is close to cortical bone. So you get stress shielding when using titanium. It rapidly forms an adherent oxide coating, which is self-passivation. So it separates the metal from the surrounding fluid, so you have less corrosion potential. And titanium is the only metal that does that. So what about some of the nonmetals? Polyethylene, ultra-high weight molecular polyethylene polymer is used in total joints. It's ductile, it's resilient, it's got low friction, it's viscoelastic. Remember the definition of viscoelastic. It's susceptible to abrasions. It can be altered by high temperatures or radiation. I'll let Dr. McPherson talk more specifically about this, but wear damage can be caused by third body inclusions. Wear debris can cause the osteolytic response everyone's familiar with. Your poly should be 8 millimeters or greater, or less than 6 millimeters causes increased wear. Polyethylene wear debris is a main factor affecting longevity of total joints. PMMA reaches its ultimate strength in 24 hours. It's very strong in compression, but remember, it's very ductile. It's very brittle. It does not undergo any deformation. It gets loaded till it fails. It has a low modulus of elasticity. You can reduce the porosity and increase the strength by the different the third and fourth generation cementing techniques. It mechanically interlocks with the bone. It is a grout. It is not an adhesive. The wear particles, again, can incite a macrophage response. When you insert it, be careful because you can have a drop in blood pressure. Because of the monomer, you can get an anaphylactic reaction. Cement failure occurs because of microfracture and fragmentation. Silicones are used in hand surgery, less so in other areas, particularly in rheumatoid arthritis. Polymers are used in non-weight-bearing joints of the hand. They have poor strength and wear capabilities. They have frequent fracture. They have high rates of wear debris, and the wear debris causes an immense synovitic response. Those of you who have seen silicone synovitis, it's quite impressive. There's much better implants available now. The pyrocarbonate implants, the metal implants we're using have, in certain scenarios now, have much lower wear characteristics. Ceramics, metallic and non-metallic elements are bonded ionically. This is an ionic bond. The reason I'm saying this is, again, it's because it's been asked. The ceramics are ionic bonds in a highly oxidized state. Alumina is an example of a ceramic. It's brittle, but it has a very high Young modulus of elasticity. It has low tensile strength, low yield strength, low resistance to fracture, but a very high compressive strength, and it has very low wear debris. So these things are brittle. I mean, you can load them. You have very little wear debris. They have very high compressive strength, but when they fail in a hurry, and it can be catastrophic. They have the best wear characteristics with polyethylene. They have low oxidation rate. They have less friction. They have very low friction rates, and they have diminished wear characteristics. But again, they're very brittle structures. Memorize this chart. This is a give-me question. What are the comparison Young's modulus of elasticity? Ceramics are the highest. Look at where titanium is compared to cortical bone. That's why you have less stress shielding when you use titanium. Stainless steel is more than titanium. Cobalt chrome is even higher. Look at PMMA is right around cortical bone. The lowest are cartilage and tendon and ligaments. There will be a question that says, here are all these materials. List them in order of highest to lowest Young's modulus of elasticity. Biomaterials. The unique characteristics of biomaterials are that they're viscoelastic, they demonstrate creep or cold flow, and they have the ability to self-adapt and repair. Let's talk a little more specifically about the biomechanics of bone. We're almost done, guys. You guys have been tolerating this quite well. Collagen has a low Young's modulus, as I just showed on the chart here. Look where it is, down in here. Collagen has a good tensile strength. It has poor compressive strength. Remember, bones, the collagen results in the tensile strength of bone, whereas proteoglycans are the compressive strength, as well as hydroxyapatite. The mineral portion also contributes to the compressive strength of bone. Hydroxyapatite is stiff and brittle and provides good compressive strength. Bone is anisotropic and viscoelastic, and its strongest in compression and weakest in shear. Biomechanics of fractures. Tension fractures, when you have a tension load, you get a transverse fracture. When you have a compression, it makes sense, you get a crush fracture. Shearing fractures are seen around joints. Bending, when you bend something, it fractures on the tension side, and you get a better butterfly fragment on the compression side. All of you should be familiar with that. Torsion loads cause spiral fractures, and the greatest stress is on the periosteal surface, the outer periosteal surface. Let's talk briefly about the metal implants we use. Screws. Know these definitions. Most of you should know them, but if you're not, put this to memory. A pitch is the distance between threads. The lead is the distance advanced in one revolution. The root, or the inner diameter, provides tensile strength, and the outer diameter provides pull-out strength. So look at the outer diameter and the root diameter. root diameter, outer diameter here. So what do you want to do to maximize the pull-out strength of a screw? You want to have a large outer diameter, a small root diameter, and a fine pitch. Okay? Plates. The strength is based on the material and the moment of inertia. Bending rigidity of plate is proportional to the thickness to the third power. Remember I said that before. So plates are most affected on the tension side of the bone. So if you're going to plate a femur, you want to put it on the tension side. The only place we don't do that routinely is in the forearm, where we often put the plates volarly, the compression side, because of soft tissue problems from dorsal plating. But fortunately, volar plating is adequate enough to get these stabilize these fractures and allow them to heal. Plates are load-bearing devices, okay, as opposed to intramedullary nails, which are load-sharing devices. So intramedullary nails have a high polar moment of inertia. The bending rigidity is proportional to the fourth power. They're load-sharing devices. They provide torsional and bending rigidity. They're better at resisting bending forces, and hoop stresses are lowest for slotted titanium nails. And that's why a lot of these intramedullary nails for femur fractures were using more and more titanium nails because of the decrease in hoop stresses during insertion. They love external fixture questions. Stability of fixation is maximized by the following. You bring the fracture ends into contact, which is the most important. You have a rigid construct. You can use larger diameter pins. You can use multiple pins. You can decrease the pin to rod distance. Pins in different planes, multiplanar frames. You can stack the rods. You can use rods in different planes. And in pin placement near to the fracture site and further away gives you a nice rigid construct as well. The last section is joint biomechanics. Most joints have 6 degrees of freedom. The joint reactive force, and this has been asked several times, the force is the force generated within a joint in response to external forces. So it's results from muscle contractions. They're the major contributors of joint reaction force. The instant center of rotation is at the point at which the joint rotates, and and most of the time the instant center of rotation changes developing on the position of the joint. Friction is the resistance between two bodies. Lubrication decreases the coefficient of friction. Look at the coefficient of friction of the human joint. Normal, 0.002 to 0.04. In best case scenarios of total joint arthroplasty, you have 0.05 to 0.15. It's a factor of 10 worse than, it's a factor of 10 less than a normal human joint. So obviously, we're never going to achieve the perfect, we're not there yet in terms of achieving the perfect joint replacement. Elastohydrodynamic lubrication is a primary lubrication of articular cartilage. It's, again, another definition. Functional range of motion of the hip, 90 degrees of flexion, 20 of abduction, 0 internal, 20 external rotation. Joint reaction force is 3 to 6 times the body weight. Again, joint reaction force is due to muscle contraction across the joint. The cane in the contralateral hand reduces joint reaction force by up to 60% because it increases your moment arm and decreases your muscle contraction. And remember, muscle contraction is what's most affects your joint reactive force. Hip arthrodesis, you always see these arthrodesis, where do you fuse? We're not doing as many hip fusions as elbow fusions and so forth as we've done in the past. But for some reason, they like to ask, what position do you fuse these joints? So hip arthrodesis, 20 to 30 degrees of flexion, 0 abduction, and neutral rotation. Knee biomechanics, the average range of motion is 10 to 130. 117 degrees is the average needed for squatting, 110 degrees from rising from a chair. Look at the knee biomechanics. You can look at ACL peak loads and ultimate strength. Patellofemoral joint, while running, experiences 7 times body weight. So that should be very clear why people have so many problems with anterior knee pain, why runners have so many problems with anterior knee pain. The highest stresses across the body occur at the patellofemoral joint, 7 times the body weight. Knee arthrodesis position, 0 to 7 degrees of valgus, 10 to 15 degrees of flexion. Ankle and foot biomechanics, the instant center of rotation is the talus. Average range of motion is listed. Arthrodesis position of the ankle, 0 degrees of dorsiflexion, 5 to 10 degrees of external rotation, 5 degrees of valgus. Do not put them in varus. And if you look at the foot at running, it's only 3 times body weight compared to the patellofemoral joint, which is 7 times body weight. Spine, who cares? No, I'm sorry. motion segment, 2 vertebra and intervening soft tissues, 6 degrees of motion after about 3 axes. The center of body, there's some debate. Is it anterior to S2 and so forth? They're not going to ask you specifically where the center of gravity is, but remember, it's important to know the center of gravity in terms when you're doing free body diagrams. The disc is viscoelastic and demonstrates creep. It deforms with time, just like most of the musculoskeletal tissues. They all have these material properties. The disc pressure is lowest in the supine position. It's lowest when the load is carried close to the body, and highest when it's carried further. Fatigue loading of the vertebrae results in pars fractures. Compression fractures occur at end plates. Osteoporosis, you get loss of horizontal trabeculi with resulting loss of vertebral stiffness. That's why you have so many problems with fractures, insufficiency fractures of the vertebral spine. Shoulder, 2-to-1 ratio. Remember this, comes up over and over again. Glenohumeral motion is 120 degrees. Scapulothoracic motion is 60 degrees. Stability of the shoulder, it's limited bony stability. The inferior glenohumeral ligament pops up again and again. It's the most important static stabilizer of the shoulder. Dr. Miller will talk more specifically on his lecture on Saturday. Inferior subluxation of the humeral head is prevented by negative intra-articular pressures. The rotator cuff is the dynamic stabilizer of the shoulder. Stress on the posterior capsule is highest in follow-through phase of throwing. When you're looking at a pitcher, they occasionally ask questions about pitchers. Deceleration is the most violent phase of pitching. Rotator cuff is a principal decelerator and is susceptible to injury. Obviously, the medial collateral ligament of the elbow is also susceptible to injury in these pitchers. Shoulder arthrodesis position, 30 degrees of abduction, 20 degrees of forward flexion, and 40 degrees of internal rotation, so 20, 30, 40. Elbow, center of rotation is the trochlea. Functional range of motion is 30 to 130 and 50 to 50. 50 pronation, 50 supination. Stability, the most important stabilizer to valgus load is the medial collateral ligament. I know Dr. Schul will talk more about this in the anatomy section. The secondary stabilizer to valgus load is the radial head. As long as you're not a pitcher, if you disrupt your medial collateral ligament, your radial head is intact, you should do fine. The lateral stability is provided, and it's being more recognized, posterior lateral instability problems. The lateral collateral ligament, the ulnar portion of the lateral collateral ligament, the anconeus, and the capsule provide stability on the lateral side of the elbow. Valgus extension overload occurs during leg cocking and early acceleration phases of throwing, causes problems with medial collateral ligament insufficiency. What positions do you fuse the elbows? If you're going to do one unilateral fusion, you do 90 degrees of flexion. If you need to do bilateral fusions, again, this was an OIT question about 3-4 years ago. I don't think you're going to see this anymore, but one elbow at 110 degrees of flexion for feeding and second elbow at 65 degrees of flexion for perineal care. Last, wrist biomechanics. The instant center of motion is the head of the capitate. You see the natural range of motion of flexion extension, radial ulnar deviation. Flexion extension, 2/3 of it occurs in the radiocarpal joint. You do get flexion extension through the midcarpal joint as well, and that's 1/3 occurs through the midcarpal joint. Distal radius is 80% of the DRUJ load, and the distal ulna is 20% of the DRUJ load. Wrist arthrodesis positions, if you're going to do unilateral, about 10 degrees of extension. If you're going to do bilateral, the second fusion is in a little bit of flexion as opposed to the first, which is in a little bit of extension. Hand biomechanics, normal range of motion is listed. Remember, MCP collateral ligaments are taut in flexion and lax in extension. That's why you need to position an intrinsic plus position to prevent contractures. MCP joint contractures. Here's, again, a chart showing the hand arthrodesis positions. MCP joint, PIP joints, DIP joints. The thumb CMC you want to fuse so in a position of opposition. MCP is in slight flexion again to help maximize pinch and grip, and the IP joint in slight flexion. All right. So education is what remains after one has forgotten everything you learned in school. So remember that. If you don't remember anything that I taught you today, you just got to get through this board exam. So, test questions. Last section, guys, so let's hear it and get through this. In the analysis of mechanical forces, a moment is caused by what? Front row here. Yell it out. Start over middle right here. Right, force acting distance from a point. The linear relationship between an applied stress and the resultant deformation defines the materials. Next. Good. Mass moment of inertia is defined as a resistance to. Next. Good. Which of the following is the major contributory factor to joint contact force? Muscle contraction. Start over here, guys. In total hip replacement, moving the abductor attachment away from the joint center will do which to the following? You increase the abductor moment arm, so you decrease the joint reactive force, the muscle contraction. A person will become more fatigued when holding a weight at arm's length from the chest rather than close to the chest, primarily because which one? Last one. The moments of the weight and the arm around the spine are increased. Right. Which of the following is a characteristic of a viscoelastic material? Good. See again, definitions. These are right out of exams. Which of the following will help prevent corrosion of an implant? Good. And titanium does it on its own. All right, let's go to the second row up here. A material that has the same mechanical properties in all directions is referred to as isotropic. Good. The bending stiffness of a half pin is proportional to the radius of the pin to what power? Next. Fourth. Good. The deformation of a material with respect to its original shape as a result of an applied load is referred to as anyone? What is it? Strain, right? It's the change in shape over its original shape and has no units. The resistance of a structure to deformation from an applied load is called? They're just taking the same question and rewording it to confuse you. But it should be stiffness, right? Okay, here's the question. For the four materials, cortical bone, PMMA, stainless steel, and titanium, what is the order of increasing elastic modulus of stiffness? So what's the least? One, two, three, four, five, guys. Good. Doubling the thickness of a metal plate will have which of the following results on its mechanical properties? To what power is it? Third, so bending stiffness. Bending stiffness increases 8 times. The stiffness of external fixation systems for small bones is increased when okay. A large amount of comminution and soft tissue damage associated with a fracture reflects what? Right, the kinetic energy imparted to the bone was large. Cortical bone exhibits its greatest strength when subjected to, when is bone the strongest? Compression. Because that's because of your hydroxyapatite as well as your proteoglycans. Most biologic materials are anisotropic, meaning that their stress-strain curve exhibits direction of load application. Good. What is the most likely mode of failure seen in fracture fixation device about which a non-union of the bone has developed? Which one is it? Fatigue. When a long bone is subjected to a bending moment, the greatest tensile stresses are located where? At the periosteal surface. A patient has a comminuted spiral fracture of the femur. The most likely mode of loading that produces this fracture is what? High velocity torsion. Great. Which of the following is considered the most important factor that influences the torsional strength of a hollow stainless steel intramedullary rod? So what is it? It's your diameter, right? Or it's your radius to the fourth. Which of the following factors will increase the rigidity of an external fixation device? If you decrease the distance of the sideboard to the bone surface, that's the best answer in this scenario. Gives you increased rigidity. Which of the following combinations exhibit the greatest amount of crevice corrosion? Now, you should know the answer to this is stainless steel. Anything with stainless steel has the highest amount of crevice corrosion. So which one of these, stainless steel and what? Cobalt chrome. More so than aluminum. Right. Alumina, the ceramic. Good. Don't pull an all-nighter for your test, guys. You guys are going to do great. Who are these? Who's this? And who's that? Who's that? Anyone know? No? Pat Ramsey, and Redskins will win Super Bowl this year. To my kids. Good luck, guys. I think we have a break now.